to collect in this research seminar researchers of different parts of the world and faculty that are experts in the different fields. We try to share ideas, knowledge, and to think about the future of mental health. In particular, in this occasion, we have the opportunity to share ideas too about this moment that is very complicated. Last year, we canceled our research seminar. The COVID-19 was for all, and in particular for the fragile people, in particular for children and adolescents, a very, very important moment of difficulties. And today, in this session, we try to discuss about this. We try to think about what happened and what we have to do, what we can do together, how the science can be supportive of this process of change of the system of care. Pandemic was a crucial topic for many countries around the world. We discussed this in the G20 conference few days ago in Rome, and we have two sessions, a pre-conference session about mental health. We decided together, the chief of the different countries, that this area had to be crucial for the future. We have to invest more resource, more research, more knowledge in this field. I think this is the moment in which we have to restart, but we have to know that we have many sufferings behind us that we have to face, and we have many difficulties, and not only in mental health, but in social area that we have to face. I like to start after the message that we received from the Holy Father. The Holy Father say, on the occasion of the conference of the mental health of children and adolescents taking place in Rome, in the context of the 16th edition of the International Research Training Seminar in Child and Adolescent Psychiatry, organized by the Università of Modena, Reggio Emilia, and the Child Foundation, and supported by prestigious international institutions, Pope Francis wishes to extend his cordial greetings to the distinguished speakers and participants, expressing his deep appreciation for the events. The Holy Father is deeply concerned about the serious psychological and emotional repercussion of the current pandemic on children and adolescents, especially the most fragile and vulnerable among them. He hopes that this initiative, aimed at raising awareness about a topic that is delicate and is urgent, will promote fruitful collaboration and broad convergence in order to foster an authentically human approach to care, attentive to people and their experience. His Holiness is thanking you for your commitment. Wish all the best for the Congress work, and willing sends his blessing greetings. This is the message of the Holy Father sent to us by Cardinal Parolin. And this will be to the occasion, this meeting, to collect ideas for a conference that we like to organize in the Academy of Science in February next year, together with UNESCO, UNICEF, and WHO. I think this is the moment in which we have to think together. I think that mental health had to be a very important area of interest. Now I like to share with you some ideas that we can discuss today in our meeting. We had one issue that was crucial for all the part of the world, that the schools were closed all over the world in a different way. In Italy, more than in other countries at the beginning. And this was a crucial moment for their children, not to have a point of reference for many of them, for education, for growth, and to stay at home was a good opportunity for some children, small children, less for older children, and particularly for adolescents. And the interaction between children were a very complicated issue, not to stay with their peers, not to have the opportunity for sport or other activities. And to the relation with the grandparents was very complicated. And this was one moment that we have to think about, the effect that this situation had in our children and adolescents. Social distancing is another important issue. After me, Fabio Lucidi will speak about this issue. The problem that we saw is that we had in many families that were dysfunctional, a lot of difficulties. In particular, we had violence, and we have many reports of abuse in many families that were fragile, in difficulties. But all the families were in a very complicated situation. In particular, in Italy, after the second wave, that was quite unexpected, and it was complicated to be back in the family and think about one future that was very, very, very confusing. Two, because we don't have any solution for the pandemic. And in this case, we have many difficulties too in the service that were in charge of mental health. We had the data that from UNICEF that we have many effects of COVID-19 in the population of children and adolescents, and we collected in many journals in our field data about the problem. Data that were more in, if you like, expression of few groups of people that collected their clinical experience, and now I think we have to do more research about all the data that we have to collect together to know what happens, what we can do now to read better those data. We have an increasing number of problems in the area of anxiety, depression, and in any case, this was a very crucial moment in which was difficult in any case to make any support for many family and children. We have some problems that were possible to measure as sleeping difficulty, eating disorder, irritability, boredom, feeling of loneliness. And in any case, we saw to the difficulty for some family to face the role of parenting and the role of care. And in particular, I like to underline the fact that in Italy, but in many parts of the world, the service for mental health were not able to face the problem. And we closed many of the service for many people. To adult patient was quite impossible to have the service that they had before. And we have many cases of suicide, many cases of very complicated situation in this field. I think this area we have now to go back and to see what we have to learn from this experience to avoid the fact that it can be possible to have another case, another situation in which we have to close our service. And in this case, telemedicine was not enough, in particular in the country that they don't have the idea to invest in this field. We have, after the fact that I collect some data about research that were done by some colleagues, but we see the increase of mental disorder was very, very important for many in all the countries. One area that was more complicated was the area of fragile children and handicapped children. This area, too, in Europe was complicated to face. For example, autistic children, they have a lack of care. And because the absence of the school, the absence of any educational center, create a lot of problems for the family to manage the children without any treatment, without any support from outside. We had some interesting project in some part of the world that had to be considered, but in any case, for many families to have children with difficulties were absolutely very complicated. And I think this is a topic that we have to, because we have a less report of mental health in this moment, but it's because we don't have any system of care that was open. All the hospitals were dedicated to the COVID-19, and in the field, the services were not able to restart. And one issue that we have to consider, and this is only suggestion, is that we saw that the digital solution had to be taken care, because we saw that children and adolescents and the adults utilize more the digital supplies, the digital systems. We have after some important solution for education, for example, but we have so many risks, oversharing of image, activity of gaming that were compulsive, and the use of this kind of system were absolutely increased in a way that sometimes was very, very, a very important risk factor for many, many problems. And two, I think the role of the media was crucial, because the information were very, very complicated to discuss with the children, to see the image of people that died. For small children was a complicated situation to understand if the parents were not able to discuss with them. I think that the media play an important role to create a sense of depression in the community, and without any answer. And for the children, it was not possible to share ideas between them. They don't have their peers to discuss. And in the digital area in which they were present, they don't discuss in deep about the problem. They discuss more about very, very modest issue of their normal, or of their, if you like, of their life. And if the digital technologies help some children to maintain the relationship, I think that the other area were not managed in the right way, because we don't invest at the beginning, in particular, too much to give through the digital world information to the children, to the family, how to manage the situation. We had some experience, but not enough. We work, for example, together with the Minister of Family to give advice to the family. We, as Telefono Azzurro, we work to give special information to the children. But the number of calls that we received as Telefono Azzurro in the last in those months was absolutely very high, and this was the same data that we collected by Child Helpline International, but the network of all the helplines, and we saw more and more cases of suicidal behavior and more cases of mental health disorder that were a request for help. Now I think we have to think about the future of in mental health. Means that we have to think how we can give more access to the service, to the digital solution, how we can face the problem of the stigma through the digital world, because for the children it's more easy to speak through chat than have a direct contact. And if we utilize this system, this can be a good opportunity to care. Many cases, sometimes cases that don't ask for help in presence. We need tools that are able to answer to the request of the children. We can have some system with chatbot that can be effective to give the sense of presence of somebody with children and adolescents in difficulties. And I think we have to elaborate new tools. We have to measure their effectiveness, and we have to train psychologists and psychiatrists in this field. I am sometimes very surprised to see many psychotherapists open line to answer to the request through WhatsApp and other chat without any training in this area. It's not a problem to use digital, it's to know how to use this system and to have an opportunity that in which technology can be effective to support the professional role of psychiatry and psychologists. And we have to see and discuss together about the different role that we have internet compared by the in-presence activities. We have to know what we can do in emergency through the digital solution. And I think the experience that we had, for example, in Canada, in Australia, can be very helpful for us. But in any case, we have to work with the companies now in this area. For example, two big companies like to invest more in this area, in particular Google and Apple, because they know that many clients are young people and many clients like to have support from somebody that can give answer to their needs in a short time and effective way. And after I think we have to integrate more service online and face-to-face service, because in many cases we have to understand that it's impossible to care all the people in presence. We have to support project in which we can be present with the children through the digital solutions. And in particular in those months, we restart the school in many parts of the world. I think it's important to care the children in this case with the right service, either in presence, either with digital solution. And I think we have to promote a positive technology and thinking more about well-being. And not only in the area of the school, but in the area, for example, of sport, in which my friend Fabio knows very well this field. And to the experience that we had in the last Olympics, we saw young athletes that were so devastated by the experience of the Covid-19 that were not able to give the quality that they had in their experience. I think we have to train more and to make more research in this field. This is what I think is important. I think can be one of the suggestions that I can leave to the floor. Now I like to introduce Fabio Lucidi. Fabio Lucidi is professor of psychology in the Università La Sapienza of Rome. Is the dean of the Faculty of Medicine and Psychology at the University of Rome. He will speak about physical distancing in adolescence, the role of emotion, personality, motivation, and moral decision-making.
Won't you come sit over here?
Yeah.
Thank you so much. much. Ernesto, is the microphone switched on? Oh. Thank you so much. Thank you, Ernesto. Thank you to the organizer for inviting me. I'm very happy to be here in order to have an overview with you about my presentation. That starts from the fact that it's very easy to recognize that a pandemic event, a so stressful life event, have a large impact on adolescents' positive and negative emotions, raising their level of anxiety, psychological distress, affecting their well-being, their mental health. There will be a lot of topics in this session. We'll specifically address these areas of work and more generally the impact of COVID on youth. So I will not go in this way. I will try to address with you another issue that is related to the fact that COVID has not only resulted in an effect of mental health, but also in behaviors. And these behaviors in turn correlate with young health, with mental health in young people and with their psychological well-being. One of the major difficulties during adolescence, a period of life in which proximity and physical contact has a particularly high value, is complying with the rules of social distancing imposed as a result of the pandemic event. Ernesto introduced it. So the aim of my talk is to try to illustrate through the data of a longitudinal study the way in which a complex system of relationship between individual characteristics in terms of motivation, emotion, personality, may interact with the choice and behaviors in terms of social distancing adopted by the adolescents during this period. So let me move a step back in order to try to better introduce my topic, that is physical distancing behavior, that is, as you know, the key disease prevention strategy from limiting the spread of COVID-19. And adolescence is a period in which peer social interaction are totally significant, and therefore it's not surprising that these guys are reluctant to adopt physical distancing behavior. If we want to be effective in encouraging physical distancing behavior among adolescents, we have to understand the associated mental mechanism in order to communicate this issue in the right way. Because we have to point out the fact that maintaining one physical distance from others is a very complex health behavior. There is a lot of literature, and according to this literature on proxemics, a large number of factors may influence the way in which space is perceived and used in human interaction. And these factors range from trait, from different normative belief, and this can affect the way in which behavior will be adopted. So, which factors? We have factors at an emotional level, at a personality level, at a motivational level, and in this specific case, there's a lot of reflection that we can do on moral decision making. I will try to focus on each of these factors in my presentation in few minutes, starting from emotion. So, it is, I will try to focus on small literature data, but there is a reflection that is very much more large than what I will introduce in my presentations. It is clear that stressful life events, a pandemic, have a large impact on emotions, on positive and negative emotion. And this may raise the level of anxiety and psychological distress. This is quite clear, not surprising. But there are a lot of studies that has hypothesized that anxiety could make adolescents more focused on their personal health. And this may, in turn, affect their decision to be more or less engaged in physical distancing behaviors. What about personality? Personality is an interesting issue, particularly because health communication campaigns and intervention very often try to target specific subtypes of adolescent personality in trying to be more effective in changing behavior. There's a lot of classification of personality, as you know, but according to one of the most popular, that is the Big 5 personality traits models, adolescents have various different ways of thinking, very different emotional behaviors and behavioral patterns that can be described by referring to 5 broad dimensions of personality. The Big 5 that are extraversion, meaning to be oriented towards social stimuli, agreeableness, meaning to be helpful and empathetic, consciousness, being to exercise one own self-discipline, being neuroticism, being to feel themselves anxious and threatened, and open to the experience, meaning to be curious and attracted to risk. According to these 5 big traits, big factors of personality, we can describe adolescents and in general people characteristics in terms of personality. And we easily might expect that adolescents with higher level of consciousness may have stronger intention than, let me do an example, extroverted adolescent to adopt physical distancing behavior. Then let me focus on motivation. Once again, we have a lot of theoretical model of motivation, but one of the most influential model is the self-determination theory that considered, there is a very complicated model, but in general we can say that there are, according to this model, 2 main typologies of motivation that are controlled motivation, regulated by internal pressure, such as the avoidance of guilt, shame, external factors, reward or punishment, and autonomous motivation that entails personal beliefs of the intrinsic value of a specific social object, such as an activity. There is a lot of literature about motivation and physical distancing behavior, but according to a very recent data by Osterhoff and colleagues, adolescents motivated by autonomous reason may be more likely to engage in physical distancing behavior. We are not talking about a choice without ethical implication in this case, because we are in the considering this kind of behavior in terms of a possibility that one social interaction during a pandemic may infect others. So moral decision making is an important variable in predicting this kind of behavior. There are recent data, more or less recent, 5 years or more, that shown that moral disengagement may mediate the effect of some motivational variables, such as autonomous or controlled motivation, on ethically problematic outcomes. For those who are not so familiar with social cognitive model, moral disengagement refers to some mental mechanism which facilitate engaging in unethical behavior without feeling distressed from this behavior, without feeling guilt. Example of this mechanism may include the euphemistic labeling, for example, thinking that not adopting this kind of behavior, physical distancing behavior, is a way of exerting one's freedom of choice or the distortion of consequences. For example, thinking that minimizing the negative effect, for example, minimizing the negative effect of not adopting physical distancing behavior, or the diffusion of responsibility. For example, thinking that individuals who don't adopt physical distancing behavior should not be blamed because most other people do not adopt them either. Physical distancing is a complex behavior, and like all complex behavior, requires an amount of planning. So it is not plausible that it could be automatically stimulated by psychological states without the presence of a prior decision and definite intention to perform this kind of behavior. In other terms, intention are considered self-instruction to perform specific behavior related to an intention, such as I intend to engage in physical distancing behavior in order to obtain determined outcomes. So it's a goal-directed behavior. Given these premises, the general purpose of the study I will present you is to preliminarily evaluate changes in the level of positive and negative affect after the national lockdown here in Italy, compared with the same period 1 year earlier. Then we conducted a study in order to evaluate the possibility that some factors proposed in the literature would be real predictors of adolescents' behavior in terms of physical distancing behavior. And then we tested a model in accordance with some experimental data and with some theories in social and health psychology. This is the model we tested and hypothesized. According to what I premised you, we tested the idea that physical distancing behavior is a goal-directed behavior predicted by the intention to perform it, and that the intention may be in turn predicted by personality factors, by emotions in terms of positive and negative affect, and by motivation in two ways: in a direct way, in which motivation directly influences intention to perform physical distancing behavior, and in a mediated way, throughout the mediation of moral decision-making in terms of moral disengagement. So, if you want to translate it in terms of specific hypothesis, we hypothesized that after the national lockdown, negative affect would increase, while positive affect would decrease, and that these emotional changes would predict physical distancing behavior. In particular, that the increase of negative affect would predict the intention to engage in physical distancing behavior. Then we predicted that more conscious adolescents would have stronger intention to adopt physical distancing behavior, leading them to practice it more, while extroverted adolescents would have weaker intention, and then weaker physical distancing behavior. Finally, we predicted that adolescents motivated by autonomous reason would have stronger intention and would therefore engage in more physical distancing behavior. We expected then that autonomous motives to have an additional positive effect on intention and indirectly on physical distancing behavior through lowering moral disengagement. So we expect a direct and an indirect effect. Let me give you some details about the methods, in particular about the participants and the procedures. We involved in this study school classes in which teachers had joined an online educational project voluntarily, and they were selected to complete the longitudinal survey, and their students an amount of 571 students, were asked to fill in an online questionnaire on a voluntary basis, ensuring their anonymity by the use of an individual chosen password. We had 4 times in which we performed our study. At time 0, it was April 29, so about 1 year before the first peak of the pandemic. In this situation, we collected positive and negative affect of 568 students from the number of those who were contacted, so a rejection rate not too high. At time 1, more or less 1 year after, and after the national lockdown period in May 2020. In this situation, we collected again positive and negative affect. We collected personality traits in terms of the Big 5 model, and then we collected their motivation in terms of autonomous and controlled motivation to engage in physical distancing behavior. Then we have a time 2, exactly 1 week later, time 1, so again in May 2020, in which we measure moral disengagement and the intention to engage in physical distancing behavior. And finally, 3 weeks later, time 2, we collected the effective, you will see the self-reported, physical distancing behavior. This is a way to introduce you some measure. In order to measure positive and negative affect, we use the 10-item version of the PANAS. Certainly, you know this measure. In terms of personality traits, we used the Italian 10-item personality inventory. In terms of the motivation to engage in physical distancing behavior, we use 2 scales. A scale measuring autonomous motivation, and one other measuring controlled motivation. The items of these 2 measures was based on those used in previous study with adequate psychometric indexes. In order to measure moral disengagement, we developed a new scale by means of 6 items, which are each of one referring to different moral disengagement mechanisms, such as euphemistic labeling, distortion of consequences, diffusion of responsibility, and again, psychometric indexes were adequate. We measured the intention to engage in physical distancing behavior using 2 items, adopted from a previous study conducted here in Italy. And then we measure physical distancing behavior in terms of self-report by 3 items. This is quite important, so I will decline to you. That is predicting physical distancing from others of at least 1 meter, avoiding physical contact with other people, and avoiding crowded public place as much as possible. So let me move to the results. The first question is that COVID changed positive and negative affect. And here you can see the changes of the level of positive and negative affect after the national lockdown compared to the same period 1 year earlier. And as you can see, both positive affect decreased significantly, as well as negative affect increased significantly. We use individual differences score, the score of the difference in positive affect and in negative affect between time 0 and time 1 as a predictor, as the first predictor of the intention to adopt physical distancing in behavior in time 2. And the other predictors was in terms of personality traits, the score, the individual scores in terms of extroversion, agreeableness, consciousness, neuroticism, and openness to experience. And the third set of predictors was those related to motivation to engage in physical distancing behavior in terms of controlled and autonomous motivation. We measured their impact on the intention both the direct one and the mediated by moral disengagement measured at time 2, 1. And then the intention at time 2 was used as a predictor of the physical distancing behavior. This is the one that you are seeing are the results of a structural equation model in which you can see our main results. Let me say that. Effectively, autonomous and control motivation has a significant impact on the intention. The autonomous motivation a direct impact and a mediated impact in the expected direction, while control motivation only a mediated impact on intention throughout the effect of moral disengagement. On the contrary, the different score in positive or negative effect do not exert a significant effect on the intention, and the effect of personality traits was very limited and limited to the effect of openness to experience, while extroversion, agreeableness, consciousness, despite of what we expected, show no effect on the intention. Intention, in turn, was a significant and very relevant predictor of the effective physical distancing behavior. In terms of characteristics of the participants, gender and age resulted significant predictors, being males less able to adopt physical distancing behavior and younger adolescents more able to adopt physical distancing behavior. The amount of variance of the outcome variables was quite high, arriving to the 47% of the variance. So let me decline my results in a more specific way. Changes in negative and positive emotion seems to have no effect on the intention to engage in physical distancing behavior. I have to say that these results is quite consistent with some studies showing that the effect on the emotion of the intention to engage in protective behaviors can be non-significant when at the same moment, simultaneously, you consider other motivational factors and take it into consideration, and this can be an effect that is related to the suppression of this effect throughout the motivational variables. If you consider personality traits, findings indicate that the relationship between personality and physical distancing behavior are significant, but only for the trait of openness to experience, meaning that, as one might expect, adolescents would tend to be attracted by risk, have less intention to adopt physical distancing behavior. But this effect was quite weak, and no other variables was significant in the structural equation model. With respect to moral disengagement, adolescents with an higher level of moral disengagement are less likely to adopt physical distancing behavior in the future, and this is linked to their type of motivation. In fact, as has been suggested, autonomous motivation plays a positive role in various health behavior, including physical distancing behavior, and the present study provides some empirical evidence suggesting that autonomous motivation effectively predicted adolescent adoption of physical distancing behavior 3 weeks later. On the contrary, control motivation corresponds to significantly higher levels of moral disengagement, which in turn reduce intention to engage in prevention behavior in the future. This is a summary of the model we revealed with our structural equation model, meaning that the main results are related to motivation. Autonomous motivation and control motivation exert an effect on the intention to engage in physical distancing behavior directly and throughout the mediation of moral disengagement, and that the intention is a very significant predictor of the affected behavior. If you want some take-home messages, our results suggest that messages and regulatory or enabling intervention should be oriented towards supporting adolescents' autonomy, emphasizing their personal, their social value of physical distancing behavior, as well as pointing out that the decision on whether or not to adopt this behavior is largely up to them. On the contrary, target communication intervention should try to avoid as much as possible the use of coercive strategies based, for example, on eliciting emotions such as shame or guilt, who do not adopt physical distancing behavior. These strategies could have a paradoxical effect of inhibiting preventive behavior, because in reality they are liable to trigger off mechanism of moral disengagement. We have a lot of limitation as well as other study, but it is clear that the relation between emotional and motivational state and social behavior is certainly of continuous interaction. As Ernesto pointed out in his introduction, it is quite important to assess how much changes in physical distancing behavior may influence positive and negative affect. But in this study, we were able to assess the effect in change of emotional state on the ability to adopt the required physical distancing behaviors, and not the circular relation in general. So this remains an important research question, but truly we all hope really to emerge from this condition, and then not to have the possibility to deal with this issue in the coming years. Thank you very much for your attention. This is the research group who conducted this study. Thank you.
Okay. Thank you very much, Professor Lucidi. It was very interesting. What we plan to do is we're going to do one more presentation by Andrea Danese, and then we'll take a few moments for discussion before we take our break, okay? Professor Danese was unable to be with us in person, but he has sent a recorded lecture, which we will now play. Christian or Massimiliano, can you play it?
Hello, everyone. I'm Andrea Danese. I'm professor of child and adolescent psychiatry at King's College London, and also a consultant child and adolescent psychiatrist at the South London and Moseley NHS Foundation Trust. I'm really delighted to be with you today and tell you about emotional symptoms and disorders during the COVID-19 pandemic, particularly focusing on children and young people. I will give you some background to this topic, as well as describing some of the work we have been doing with psychoeducational campaigns for mental health of children through parents, as well as more directly targeting the needs of adolescents. So to begin with, we want to think really about the background, about the epidemiology of emotional symptoms and disorders during the pandemic. And to really understand what has happened during the pandemic, we probably need to step back and think about what was happening or what has happened before the pandemic has started. To do so, I will refer initially to the data from the NHS Digital Mental Health of Children and Young People in England, which is a survey that has been repeatedly undertaken by the UK government, with the last time point here in 2017. And what we have seen in 2017 is that the rates of mental health problems in children and young people were elevated. As you see here, these bars show the prevalence of different types of disorders, emotional, behavioral, hyperactivity, and other disorders, as well as any disorders in different age ranges. In blue, the 2 to 4, in light blue, 5 to 10, light gray, 11 to 16, and dark gray, 17 to 19-year-olds. What we can learn from these data is that emotional disorders are among the most common, perhaps the most common, particularly at older ages, conditions that are present in young people. Not only that, but it's important to think about how the prevalence of this condition has changed over time. And NHS Digital, as I said, has been collecting this data repeatedly from 1999 to 2017. What we can observe in this other plot on the right-hand side is that hyperactivity disorder have remained broadly stable from 1999 to 2017. Behavioral disorders, you see, had some changes, but again, remained comparatively stable over time if we compare 1999 to 2017. In contrast, the prevalence of emotional disorders has increased from 4.3% in 1999 to 5.8% in 2017. So quite a significant increase over this time period. So this is really the starting point to then understand what has happened during the pandemic. And of course, we can think that during the pandemic, a set of risks have accumulated over time. In particular, we have all been concerned about stresses that young people have faced, particularly the perception of threat, for example, the COVID infection itself, uncertainty about the future, about education, for example, as well as the job opportunities. Financial stresses within the family, of course, because of the financial difficulties that many industries and therefore families have faced during the lockdown periods, as well as an increase in parental mental health problems during the pandemic. In addition to these stresses, the other important change has been a loss of resilience factors. For example, children and young people were isolated from friends because of the social restrictions and, for example, the inability of attend school and play with them. There has been reduction in enjoyable activities, again, because of the social restriction of the lockdown. A disruption of routines, right? So the families were not living through the same routines as in pre-pandemic period. For example, parents were both working, sometimes from home, as well as trying to educate their children, so to doing some school education at home. For some children and families, there have been severe problems with malnutrition, particularly children and young people from less privileged backgrounds who were relying on institutions to provide nutrition daily. And more generally, I suppose we have seen important challenges that have been faced by social infrastructure, like schools, social services, and our child and adolescent mental health services. So these are really the infrastructure that are normally in place to ensure that the children are safe and protected. And of course, they were not there in the periods, particularly of the lockdowns. Finally, what has been apparent is that child and adolescent mental health has been overshadowed by material and physical needs in the population. So as the priority, of course, was to think about reducing the transmission and the consequences, the burden of the pandemic, these concerns have really largely overshadowed the needs, the social, educational, and developmental needs of young people. And therefore, of course, many have suggested that the COVID pandemic would be associated, would trigger a large increase in emotional disorders in the population. And indeed, many studies have been undertaken to look at this impact. And because of time restriction, we will not have a chance to read through the details of each of the studies that I list here. But these are the main studies in the UK that have tried to test the impact of the pandemic, and particularly the lockdown, on child and adolescent mental health. And if I can summarize the findings, many of the studies, and these are longitudinal studies, have shown a worsening in mental health of children and young people, and particularly a worsening of emotional symptoms, therefore an increase in emotional disorders. However, findings have been quite mixed, and instead of a clear message that could have come from these different studies, the overall findings have been quite heterogeneous and confusing in many ways. So it's important to reflect about the lessons that we can draw from these longitudinal studies, and particularly to make sense of this heterogeneity. So on the one hand, it's plausible that the lack of consistent increase in emotional symptoms might reflect a mixture of effects, where some groups of young people experienced worsening in symptoms, for example, related to the fear of the consequences of COVID-19 infection for themselves and their loved ones, loneliness, worry about education or employment, some of the stresses that we have mentioned. However, others would have experienced no change in symptoms since pre-pandemic level or functioning. And others still might have experienced even improvement in mental health. And now I'm thinking about some of the patients I work with who are extremely anxious. And some of them, I must say, did better during the lockdown because of reduced academic and social pressures, and also reduced bullying. So this mixture of effect really might explain the heterogeneity that is observed in longitudinal study. Another important point is to think about biases in recruitment for these studies. So it's quite possible that because of the speed at which these surveys have been planned and undertaken, the recruitment does not represent the overall general population. And instead, there is a greater representation in these surveys of young people from less affected, for example, wealthier or better educated backgrounds, who therefore would have been less affected by the lockdown and the pandemic. Now, what we have discussed so far really largely reflects the concerns about emotional disorders. But it's also really important to consider that in addition to the disorder, there is an even broader and perhaps more meaningful at a population level, more meaningful impact on symptoms, so emotional symptoms in addition to disorders, and therefore the needs that young people have, and we need to identify and address. So in the middle of this complex situation, then in this complex emergency, how can we then think about a rational response? Well, I will draw some lessons here from the framework that is put forward by the NHS England, where we think about emergency preparedness, resilience, and response. So what we have done, actually we did this prior to the COVID pandemic, thinking about a public health response to several terrorist attacks that have occurred in the UK in the past few years. What we did on behalf of the Royal College of Psychiatrists was a summary and an adaptation of these principles and this framework for child and adolescent mental health amidst emergencies and disasters. So how can we learn about these public health lessons, and how can we apply them to child and adolescent mental health? Well, I will highlight here an important point, which is that what we can do, of course, in addition to other components, for example, screening, is really to develop evidence-based and clear messages, so psychoeducational material that can help both in terms of preparedness as well as response. With regard to preparedness, it's really important to think about communication. So in peacetime, as it were, so in conditions where there is no emergency at present, it's really important to prepare accessible written material based on sound clinical advice that addresses the key mental health concerns that are typically present in the context of emergencies. Secondly, and perhaps most relevant to our context at the moment, we need to think about the emergency response. And of course, the emergency response involves different levels of interventions in a stepped care framework. So we move from universal low-intensity interventions to specialist high-intensity ones. And in particular, at the universal and low-intensity end of the intervention, we really want to highlight the role of psychological first aid, and within psychological first aid, psychoeducation. So I should say psychological first aid really is a set of practical actions that are typically taken by trained non-health professionals that aim at promoting safety and comfort, and crucially, as you see, developing and providing information on coping strategy at the population level. So these are not typically evidence-based, but they are commonly used by all the key institutions that operate in this area, including WHO and the UN. So really reflecting on this lesson from our emergency and disaster responsiveness and the framework that we have in the UK, along with my clinical colleagues at the Trauma, Anxiety and Depression Clinic at the Moseley Hospital, in addition to the direct clinical work that we have undertaken with our patient, we have also developed a more public health approach, trying not only to address the disorders that we are working on with our patients, but also the broader need that we have seen, the bottom of that iceberg that I showed you previously. And this is what I will cover in the next few slides. So to begin with, we have started thinking about supporting children through parents. So to provide information to parents that would enable them to help their children through these difficult times. Initially, we have worked with the BBC, producing what we call BBC bite sizes, so succinct and practical advices for parents. In this case, you see a couple of examples on boosting positivity for families during the lockdown, as well as helping parents and children feel better about going back to school at the end of the lockdowns. However, we appreciated that in addition to being evidence-based, we wanted to really make this messaging captivating, brief, fun, and use not simply writing, as we did for the BBC bite sizes, but also audio and visual material. And of course, trying always to think about what parents need, so to give practical advice. So to do that, we joined forces with my colleague, Professor Edmund Sonogabarke at the Institute of Psychiatry. Edmund is a leader in the research and treatment of ADHD and behavioral problems. And with him, we have developed the Family Under Pressure project. Family Under Pressure aims to provide simple tips and tricks that are formulated by researchers and NHS mental health experts, so that they're backed by science and proven to work with families. Not only we have these important messages, but we have collaborated with a set of different content production companies to really make this communication as enjoyable as possible. In particular, my clinic and I have developed 4 modules that really focus on helping with negative emotions. So for example, how to communicate better with your child, helping your child cope with anxiety, helping your child manage negative emotion and feelings, and how to boost positive emotions. And I thought to show you one of these videos to give you an example of how we have developed them.
Helping your child cope with anxiety. As parents, we wish we could click our fingers and make our child's anxiety disappear. But we can't. However, we can change the way they think or behave to ease their symptoms. It's important to limit your child seeking reassurance from you all the time, because it only keeps the worry going. Instead, plan a daily worry time to encourage them to talk about their thoughts, write them down, then put the list away. Rather than worrying about things they can't change, help them take practical steps to keep them safe and healthy, like exercising, sleeping, and eating well. Maybe it's best not to play football inside, though. For more information, visit familiesunderpressure.org.
We're really happy about the results from Families Under Pressure. And these videos have been disseminated in a number of ways through the media in the UK. And also, we have been able to adapt and translate these videos and distribute them through the medias and governments in Australia and Germany. And we are currently working with other countries to similarly disseminate this video there. In addition to working with parents, we're also very interested in directly working with adolescents. Now, the reason why, of course, is that particularly focusing on emotional disorders, as we have said already, emotional disorders are most prevalent in teenagers and adolescents. And therefore, if we want to act and prevent and help and buffer emotional symptoms and disorders, we really need to work directly with young people and support them. Of course, in doing so, there are a number of barriers, particularly communication barriers in this case were most relevant. Oftentimes, we think about adolescents particularly as being disengaged with this type of communication and often isolated as well. And therefore, we worked hard against these barriers, to break these barriers, with the support of professional content production and also social media companies to develop a new set of products. Now, what is essential in this new type of work that we have done targeting directly adolescents were three really principles. The first one is co-production. Co-production as alternative, of course, to expert-led communication. And this is something we have developed with our partners, the McPean Foundation, that promotes public and patient involvement here in the UK. This is really important because in this way, by co-producing material with young people, we're able to empower young people to tell us their stories so that we could learn from young people's lived experience, also engaging other young people through empathy, so to giving the most relevant examples. And this is the process we went through. So we introduced young people recruited by the McPean Foundation to the project. And with them, we prioritized key emotions that we wanted to focus on. We discussed each emotion in detail with them, thinking about what the emotion feels like, when the emotion is experienced, and how young people cope with these emotions. We have done scripting and design by our content production partners, Toad, and we got feedback from young people on this. We collected then videos from young people recruited by Toad so that the stories that we collected were told in their own voices to, again, highlight elements of reality and relevance to the stories. We have then selected the stories that were most in line with the clinical advice that we wanted to highlight, working with young people to polish and refine the videos. We have presented the final product to young people for feedback and adjustment for future productions. And finally, we have worked with young people to create social media content that has then been disseminated by our social media partner, Passion Digital. We have focused on emotions rather than psychiatric disorders, highlighting 3 key emotions: fundamental emotion of anxiety, sadness, and anger. We thought this was really important because everyone experiences these emotions, and therefore the content is universal. Also, we don't draw a line between what is normal and abnormal, and therefore the communication triggers and has to face less stigma. And finally, we worked intensely with social media instead of the conventional media. This is because we wanted to speak the language of the adolescents we wanted to target, and of course meet them where it was most convenient for them, where we know they spend a lot of their time. So the results is the Keep Cool mental health campaign, and I'm going to share with you the 3 main videos that were developed through this framework. The first one was released on the 19th of March 2021 and was focused on anxiety.
My anxiety
makes me shake inside.
My heart pounds. I can't focus on anything.
I feel out of control.
Overwhelmed. Isolated.
Some thoughts come back again
And again.
And again.
and I can't make them stop.
I feel anxious when I have something coming up.
Things that tend to make it worse, probably the biggest one is social media.
Work and deadlines, like, is it good enough? Will I get it in on time? I don't know if I can do this.
It's facing it, you know, and sort of staring it down and not shying away from it.
There's no need to feel ashamed. There are ways to make it feel more manageable and less overwhelming.
Breathing in 3 times really deep, and then you look around the room and you name the 5 things you can see.
Art really helps me get out of my own head.
Making sure I'm on top of my fitness because it makes me feel a lot more comfortable in my own body.
Put down my phone, go on a nice walk out in nature and just absorb all the positivity in life.
I find that writing down my worries helps me with my anxieties.
When I feel anxious, I put on my favourite song and dance in my room like no one is watching.
It's a process that takes a while, but at the end of each day, I feel so proud of myself because it reminds me how incredibly strong I am and how incredibly strong anyone with anxiety is.
Very well, so this was the first video on anxiety. The second video on sadness was released on the 13th of May, 2021 and focused on sadness, as I said.
Sadness.
It just makes me feel like I'm alone.
Empty.
Hopeless.
I lose all my energy.
I feel blank.
Stuck.
Weighed down.
Like a heavy rock
that I can't get off my back.
I could literally just think about a time like a year ago that I did something wrong and just keep thinking about it.
Not looking like people do on social media.
When you're passionate about something and it just doesn't pay off the way you wanted it to.
And all of it can sort of just tumble and have a snowball effect.
Absolutely everybody feels sad sometimes and there's lots you can do to get back up.
I can find it really difficult to reach out to people. Something I've started to do is to send emojis to friends, gifts, silly animal videos, until I feel able to meet up face to face.
When I'm feeling down, I often can't be bothered to start drawing. I know that if I pick up a pen and scribble it all down as a sketch, it feels so good to be able to remember what I'm capable of creating.
What helps me is making healthy meals, giving lettuce, aubergine, tomato, anything, and I'll make a salad out of it. Good energy the next day.
Do something kind, even if it's just making a cup of tea for someone else.
When I am sad and there's a bunch of negative thoughts keeping my head stuck in the past, Sitting down to meditate is massive for me. The breathing gives me some distance from those thoughts, gets me into here and now.
And I'll show you now the final video that we have produced and co-produced with young people. It was released on the 22nd of July 2021, focusing on anger.
Anger
makes me feel on edge, tense,
like a sharp pain in my chest,
like I'm ready to lash out.
I feel frustrated, pent up,
out of control,
like a volcano ready to explode.
Seeing anybody being treated unfairly in a situation makes me really angry.
When people don't understand how I'm feeling.
Bad people getting away with doing bad things.
The key is recognising the early warning signs.
Because everybody gets angry sometimes, but if you can try not to let it get the better of you, you can use it.
I usually take myself away from the situation, put on some music and work on my breathing.
I like to make a mindful cup of tea. Putting the tea bag in, can you smell anything when you drop the tea bag? When you pour the water, does the smell increase? What does the steam look like?
I let all of my anger out by writing down exactly how I feel. Not only does this help me get my anger out, but it also helps me see why I'm so angry in the first place.
I had to find within myself to actually let people know how I'm feeling.
When you get really angry, it can be hard to see the situation from the correct perspective. A good thing to do is to ask someone who's completely unrelated. They can give you a fresh understanding, and you can see it from both sides.
Boxing's really helped me to control my anger. Come to training, all of the anger's gone. Just the hitting of the bag, the punching of the pads, it just releases all anger, and I'm free. I'm good again.
I ask myself, is there some action that I can take so I don't feel so helpless? And how can I actually use my anger as a fuel for change?
Very well. I hope you enjoyed the videos as much as we have enjoyed co-producing them with young people, and really can see how focusing on the what, the when, and the how really provides young people with information to understand and cope with this fundamental emotion. I want to finish by thanking Matt Kiseleva, who was the research assistant on this project and really greatly helped putting the various resources together. And I really urge you to check out our social media channels, as well as the in-depth material that is then linked to all these videos on our website at King's College London, which we hope can provide with information needed to improve the emotional responses in young people, not just in the UK, but in other countries too. So we have seen that the pandemic has triggered most likely a increase in emotional disorders as well as burden in emotional symptoms. And I showed you some examples of the works that we have been doing, not simply to focus on the clinical work to support children and young people through these difficult past few months, but also more broadly to think about a public health approach and a psychoeducational message through our campaigns. I want to thank the funders, and finally, thank you very much for your attention.
Ask you to, I like to, when I invite Johannes Hebebrand to come with us to present, I like only to remember that Andrea Danese, that is wonderful colleague to you, that we saw 2 days ago in our meeting, is a special person that is able to introduce new idea in our field, because we work together, for example, in all the system with the digital opportunity to listen and intervene with the children, and to use the social media, and how to use this kind of message that are very important to speak with the children, because child participation has to be crucial for the next years, and we have to speak with adolescents and children to know better what we can do together. Johannes Hebebrand is a special person. He's a child psychiatrist. In Germany, he plays a crucial role. He's from the University of Duisburg-Essen, and I know him from a long time because he is the editor of the European Journal of Child Psychiatry. It's the most important journal in our field, in Europe in particular. But I know the story of this journal. I know how he tried to create a very important network of scientists around this process. And I asked Johannes to present about, his presentation will be about the impact of COVID on the mental health of youth and in Europe. Please.
Thank you very much for the... I got it. Okay, thank you. So thank you very much for the kind invitation to come here. What I want to do today is to introduce you to some aspects that I deem important for understanding the effects of the COVID-19 pandemic on children and adolescents, particularly their mental health. I'm going to do this I'm not an expert either in COVID-19 nor in epidemiology, so I'm trying to focus on work that I encountered during my, as a editor in the work that I've been doing for the journal. First of all, the potential effects of the pandemic on children and adolescents. We've talked about this. Basically, you're well aware of all of this. Maybe the important thing is that we're also talking about the fear of infection in itself, the lack of recreational activities outside of the home, parental stress, abuse, domestic violence. All of this goes into this. So the potential effects of the pandemic on child and adolescent psychiatry, first of all, there were units closed. In Germany, many units closed, acute wards actually even had to be closed. The communication with families was obviously hampered, and the increased workload, stress for employees, risk of burnout, increased organizational demands, and novel technology were all necessary to adapt to this pandemic. I'm not sure I have the right presentation. Is this the? I think it's the old one, Bennett. I'm somewhat confused because I gave you the new one this morning.
It's the one you gave me this morning.
I'm sorry then. Are you sure? Yeah. Okay.
We can load it real quickly.
You have it on your stick? No, I have it on my laptop. If I can just hook up the laptop.
That'll be fine.
I'm sorry.
Christian, can you come down and help us out? Christian. It may not directly connect. Christian, can you come give us a hand real quickly?
so I'm sorry. I was really confused. I must have swatched the files. So the conflicts of interest, obviously, the work I'm going to be presenting was mainly based on my position as editor-in-chief of European Child and Adolescent Psychiatry. I will explain why. But I'm also a board member of the European Society of Child and Adolescent Psychiatry, and as such have been involved with work done during the pandemic, and especially to assess the effects of mental health problems in children and adolescents. I'd very much like to thank Alexis Rivit, Paul Klauser, to name two of the people listed here, who have worked on two surveys that I will, the data of which I will be presenting during this talk. Now, first of all, I think it's crucial to remember that we are talking about specific cultural situations in which we perceive or experience this pandemic. And I was fascinated by a Chinese article that arrived early in 2020. And obviously, if you read such an article, then you realize the major difference in cultural aspects that we're facing during the COVID-19 pandemic. So if you read this, I just briefly want to read this in total so you get an idea of how the Chinese were coping with this. When children are diagnosed as COVID-19 positive, they are transferred to designated pediatric hospitals. And if their parents, as is usually the case, are also infected with COVID-19, these too will be transferred to designated hospitals for adults. Moreover, close contacts, including non-infected parents, will also be transferred to quarantine centers and stay there for at least 14 days. Therefore, the infected children necessarily face separation from their parents to stay in an isolation ward. They do not have contact with other infected children in the same ward. So this gives you an idea of how people in China were dealing with children with infections. And obviously, this is totally different from the situation we encounter in Europe or in the United States. And not surprisingly, the authors of this article, which reached us or was published online in May 2020, so very early on during the pandemic, they state that about 10% of the children have experienced trauma due to the infection and its consequences and might be diagnosed with post-traumatic stress disorder. The first survey that we conducted was based on work done with Alexis and Paul, and we wanted to have an estimation of the impact on child and adolescent psychiatric services in Europe. So for this purpose, we contacted Child and Adolescent Psychiatric University Service in ESCAP member countries and invited them to complete an online service, online self-report questionnaire. And the first stage was conducted in March, April 2020. Many of you will remember this time period in Germany was the time period during which quarantine was first established, or where social distancing was, school closures went about. And so there were a substantial reduction in the number of both outpatient visits and hospital admissions. There was a moderate, these experts rated that there was a moderate effect on psychopathology, and there was a profound effect on the organization of services with clear acceleration in the adoption of new technologies, including telepsychiatry. These are the number of respondents, so you can see that a total of about 170 people, experts, were contacted from all these different European countries or ESCAP member countries, and that about roughly half of them responded, and 56, or about 1/3 of them, completed the questionnaire. So I've gone through this, but just to give you an idea of what, back at that time, again, mid-April to mid-May 2020, they were asked what kind of disorders actually increased during this time, during these few months of the initial pandemic. And you will see that actually Many said nothing has increased. Almost 30 or 35% of the participants said there's no change. But otherwise, anxiety disorders rank prominently, conduct disorders, adjustment disorders, and OCD. And look at major depression at the end of, almost at the end of this slide. And it was just a very minor increase. Now, the second survey was conducted a year later in March, April of 2021, and we now sent this survey to 266 heads of psychiatric departments, university departments in 32 countries. Astonishingly, or maybe not astonishingly, way you may think of this, the response rate was much lower, so there was much more fascination with this topic a year ago than in 2021, and only 60 filled in the questionnaire completely, so rather very different rate in response. And as in the former survey, Germany had the highest number of responses, but there were some countries that did not respond at all. Now, what did these professionals actually see, witness? And look at the Y scale, the percentages goes up way higher, much higher than previously. And the green bar marks the period April-May 2020, and the blue bars mark the period January-February 21. And you can see that actually basically everybody has now the listing of no changes whatsoever didn't occur anymore. And we see that basically a lot of these disorders increase substantially according to the impression of these specialists. And actually 4 disorders or 4 problems rank prominently. These are anxiety disorders, major depression, eating disorders, a very strong increase, and suicidal crises also increased substantially. So the impact of the pandemic on mental health was now judged very differently. Again, green bars back 2020 and blue bars this year. And you can see that basically the low or negligible influence back in 2020 has now disappeared, and most professionals rank the impact as strong to extreme in 2021. Now, what is the influence on psychopathology according to these experts? Do they see specific patients? Do they see or symptoms in patients that were induced by the pandemic? And yes, there's also been an increase in the effects of the pandemic directly on psychopathology. Now, what are the determinants with the greatest impact on, assuming, according again to the subjective answers of these responses of these professionals? And in green are now is the younger age period, in blue is the older age period, 13 through 18 years. And you can see that the effects were judged differentially according to age, with, for instance, closure of schools being of equal importance to both the younger and older individuals. But for instance, home confinement was more important for the adolescents. Assembly restrictions, again, more important for adolescents, and vice versa. For instance, the parental stress was deemed more important for the younger children. Travel restrictions, low ranks to begin with, but obviously also more important for the older, for the adolescents. I would like to then go through 2 studies very briefly, illustrating that we hardly have any solid data. The longitudinal studies have not really been conducted that frequently. especially longitudinal studies that were started based on the wish or the desire to aim to describe the effects of the pandemic. So we have longitudinal studies that started, like, for instance, as shown previously, 2019, and then go through the period of the pandemic. But these studies were not specifically geared to assess the effects of the pandemic. So this is a methodological limitation in many of these surveys. And another more crucial aspect is basically that many of these surveys are cross-sectional. At the moment, for instance, ECUP is, we receive about 2 to 3 papers per week related to COVID. And unfortunately, we have to decline most of them because it's just not, the results pertain to very selective groups, or we don't even know, we don't even have a grasp of what groups these results are based on. So unfortunately, a lot of this research is difficult to publish. So this is an accepted paper. It was published this year, a German study. And I'm showing this because it has been criticized heavily in Germany due to the in the discussion, the authors illustrate or state that the effect of the pandemic has been tremendous on the mental health of children and adolescents. And it turns out that if you look closely at the methodology of the paper or the study, then you find out that, well, you can't really infer causality. And this is the major problem with most of the studies in the field. So it was conducted between May 26 and June 10th, 2020. At this time, partial lockdown, schools, leisure facilities, and most stores closed in Germany. A high number of children, as you can see. Participation rate was about 45.8%, and it was based on self-reports as of age 11 and parent proxy reports for all. The weighted data indicate representativeness for German population of about 80 million, so it's a bit complicated. But what they did is they compared the novel data, or this group, with a comparison set that they, based on a study conducted in 2017, and based on a very similar methodology. And so they argued that, well, with everything that we're showing is due to the effect of the pandemic. Obviously, this is something that can be discussed and has been discussed quite vividly. So for example, here you can see that the girls were affected more, so actually numbers almost doubled during the before and during the pandemic of, let's say, low health-related quality of life. You can see it goes from 20.4 to 44.7, and for the boys, it's before the pandemic, it's 10.4%, 35.7 during the pandemic. So substantial increases in the amounts of low health-related quality of life. So if you look at the effects that these children and adolescents stated on other aspects, so about 70% felt burdened by the pandemic, 65% found homeschooling and learning more difficult than before, 83% reported fewer social contacts, 40% impaired relationship with friends, 28% more arguments in the family, and 32% of parents reported that disputes escalated more often. Now, these are not data that can be compared to the time prior to the epidemic, so they stand by themselves and give the impression of these children and adolescents and their parents contacted within this specific study. As for the mental health problems, again, there's an increase in this German study, as you can see, for using the strengths and difficulties questionnaire. Particularly emotional symptoms increased during the pandemic, and again, we have now received letters to the editor indicating that the interpretation of this study, inferring causality, is highly problematic. I'll go to another study, the Youth in Iceland study, which I think is much more suited to at least get a grasp of the changes that have occurred, because it's done in a better methodological better methodologically. These are children who are investigated or are studied every 2 years in Iceland. So it's called the Youth in Iceland study at school. So there are two age ranges, 13 to 15 years, 16 to 18 years. And the study was conducted in 2016, 2018, and 2020. And in 2020, the investigators ran into some problems due to the closure of schools. The response rates were between 63 and 86%. The teachers distributed the paper-based questionnaires, and the students were asked to answer the survey anonymously. We'll just briefly go into the results. So if you look at depressive symptoms and mental well-being, please note if you look at the symptom checklist 90, these are the upper graphs. You can see that in the year 2020, basically depressive symptoms were higher than in the two other time periods in 2016, 2018. And the same, if you look at mental well-being, those are the lower three graphs, you can see that actually mental well-being was significantly lower. And also note that obviously there are slight gender effects or sex effects here, in that the results were somewhat more stronger in females. Again, you can look at the symptoms of the percentage of people with or probans with high depressive symptoms, girls and boys, according to the age range, and you can readily see that actually these depressive symptoms are more loaded or become more prominent among the older age groups. I would also like to take the opportunity to point out that obviously we're looking at many different effects at the same time. And if you look just at the emotional aspects, you then tend to potentially forget that there are also, I don't know if we want to call it positive effects, but there are other effects hidden, obviously, and not as much focused upon. For instance, cigarette smoking decreased substantially during the pandemic in Iceland. This is the Iceland study again. Or if you look at e-cigarette use, really dramatic drops in the amount of e-cigarette use. Or take alcohol intoxication, a problem common throughout Europe, I'm pretty sure. And again, there's a substantial reduction. My final slide pertains, because we're talking about training here. So there's been an editorial on the effects on training, the pandemic effects on training. And this was written up by Peter Deschamps and co-workers, and based on an online survey of 26 child and adolescent psychiatric trainers of the European Union of Medical Specialists, and a group discussion. And these the authors came up with 5 critical domains. So first, they said that there's a shift in the public view of mental health in young people. They argue that now the mental health aspects of children and adolescents are much more on the focus of the public, and this is actually something potentially good. Unequal effects of social distancing on mental health. So again, there's disadvantaged groups, but again, I'd like to point out that, for instance, for eating disorders, we saw a tremendous increase, and this is something, eating disorders are not commonly seen in disadvantaged families. There's changes in healthcare services. We touched that, telepsychiatry. Direct effects on training and education. I think most hospitals or departments of child and adolescent psychiatry actually saw a reduction in the training of trainees. And then there's also the crucial aspect of the resilience and personal well-being of the staff. So many of, at least in my department, for instance, many of the physicians experienced problems due to, for instance, having to cope with children at home and at the same time continue working at the hospital. So obviously this takes a toll and causes friction and stress on people who are in training in child and adolescent psychiatry. So thank you very much. I again apologize for the messed up slide.
Okay. Thank you, Johannes, for this wonderful presentation. I think we have a few papers now, but I hope in the future more, but with more scientific data, because I think we try to do paper, but sometimes the quality is not what we expect. And now we will have a short discussion about the first three presentations before the break. And
yes, go ahead, Roger.
Yeah. Thank you very much for these stimulating presentations. One of the features that seems quite confusing is the use of social distancing and physical distancing for the same. In Professor Lucidi's study, it started with social distancing, and then afterwards you referred to physical distancing. Danuta Wasserman, Jan Wijs and I published a paper in Science in the beginning of 2020 to urge to drop the notion of social distancing, because for the pandemic, physical distancing is important, but social distancing shouldn't be important because people should relate to each other. And I see this discussion coming back all the time, that we talk about social distancing while it's only physical distancing. So it's too late, and the WHO was the only one that took over using physical distancing systematically. But in our current talking, we're talking about social distancing, which for adolescents is very confusing. And I was wondering how your views are on that.
Professor, yes.
I think you're right. It's a good point. In fact, I use the terms physical distancing as well as I've published the paper using the terms, but you're right. In the self-representation of the adolescents that were interviewed in my study, the item I try to recover it in a more precious way. That was practicing physical distancing from others at least 1 meter, that is physical distancing, avoiding physical contact with other people, handshakes, hugs and kisses, that is quite confused, and avoiding crowded public places as much as possible, that is social distancing. So I think you're right, it's confused, and I think we have to go in a more precise way in the definition. Thank you.
May brief comment? Sure. I find it very amazing. I don't know, I guess it's probably the same throughout Europe, that at least in our department, the children and adolescents wear these masks basically all the time. It's not a major issue at all to have them wear the masks. I have not really had any serious disciplinary problems related to non-wearing of masks in our department. And my impression is that this is that the children and adolescents really have no major problems, much less than the adults, to my opinion, in adopting to these precautionary measures.
Do others have comments or questions? Professor Siracusano, just push the button. Don't touch it. Push it. I will get you a microphone. We're very flexible.
Now what? Okay, to Professor Lucidi, some suggestion, some idea between the relationship between the physical and the virtual distance. What we can think, because physical we know, but virtual distance, what can means?
That's great, thank you. Okay. It's a quite difficult question, Alberto, because, you know, they moved from a very close way to live between them in terms of social distances and physical distances, and they move into a more close virtual way to stay connected. So in my mind, the virtual distance was reduced, not increased, and I'm not sure that they were able to substitute a lot of aspects related to social connection in a virtual way. The effect you mentioned, the fact that the greatest impact on mental health was related to the school, to the fact that the school was closed. This is an example. In the case of the school, they were connected virtually, but they were at a physical and social distancing that was of a great impact on their mental health, in my mind. But I'm not sure I've correctly understood your question.
Yes, this is wondering about something. Now, because now the relationship between the mother and the baby is more virtual than physical. So I think that we can think about the problem.
I think you're right. We have to think about it. At the same time, I think that they are made of muscles and skin and body, and I think that they have to socialize in a way in which the previous question was very clear and very well focused. But at the same time, there is a social distance that is induced by physical distance, in my mind. And this kind of distance is something that we have to consider.
So Rwanda, and then Professor Albano.
Hi, my question is also for Professor Lucidi. Fantastic study and information about physical distancing. I wasn't sure about your time frame. You began your samples in April 2019?
You're right. It was
Did you know there was going to be a pandemic?
No,
I was just confused.
Yes, it was a survey that started in 2019, and then we changed the survey after the pandemic event, and we changed the question we made at the.
So it had a different purpose at that time.
Yes.
Okay.
You're right.
Thank you.
Had advanced knowledge of the pandemic.
All right, it's like you psychic.
Very special about it being in Italy. Professor Albano.
Thank you for those presentations, very stimulating and interesting. As I was listening to you, especially talking about motivation and the emotional reactions of the youth, one of the things I was thinking about is, at least in our country, my colleague John Piacentini and I work on two different coasts, but we do very similar things. And in working with families, especially with adolescents over the course of the pandemic, what we were very much aware of when it came to respecting physical distancing for adolescents was the interaction of their developmental stage and the tasks of development, the need for social interaction and contact, the need for expressing their autonomy and having more independence in decision making. These things were playing in from a developmental perspective as to who was able to accept the situation as it is and have the value and hold the value of needing and wanting to do what was right to protect themselves and family members. So that was one thing, and I don't know if you looked at that. And that also then interacted with another variable that is always there when we work with kids, and that is the parental over control or lack of control, right? In the way that the family environment was, how that interacted then with whether the families were able to, and we did a lot of work with them, think through and be flexible in ways of allowing some contact for the youth in safe situations and ways to do that, giving them the perception that they could make decisions to be physically near others in terms of keeping the 6 feet in our country distance, right? But to be able to satisfy the needs that a developing adolescent has without then violating, major issues that would get into difficulty. So these are all things that were being balanced and we're trying to study, and I don't know where that came in. The parental factors as well as the developmental, trajectory that these youth are on. And I'll just add another layer of complexity, of course, is that, like, especially where I am in New York City, you have families living in apartment buildings, and especially then when we look at our lower income and disadvantaged families who are in public housing, very small spaces, multi-generations in a tiny little box, not being able to get out. There was a lot of breaking out of the box, so to speak, and kids breaking rules because they were so confined. And so there's data coming in that's showing, of course, more advantaged youth from families that are more advantaged were faring better during the pandemic because they had places to go that had outdoor space, whereas the kids in the urban areas had more difficulty, and it is mediated too, again, by income level for how things went. So I don't know where in your data if you are looking at that.
I think that here is a comment more than a question, and my comment to your comments, I agree with you. The first point that I want to mention is one of the several limitations of what I presented to you. Mm-hmm. My data are based on self-reported data. So I am able to say that 47% of the self-perceived, self-reported ability to cope with physical, confused with social mm-hmm. distances, are controlled by the intention of the person. Mm-hmm. I think that there is a part that is not perceived and a part that is not controlled by the intention. And both these parts are related to what you mentioned in a very strict way. The point is that part of this behavior should be controlled by the adolescents themselves, and this part can be emphasized using a way to, you mentioned over control or under control by parents. I think that the point is not how much, but how they try to influence this kind of behavior, and the point of my data are related to autonomous motivation that can be emphasized.
John, you had a comment? And then Carolee.
Professor Hebebrand, I thought the Icelandic study was very interesting in the sense that some of the high-risk behaviors had decreased of smoking and drinking. And my initial thought was that's because kids are physically distanced, and it's less fun to do those things alone than with others. But I also wonder if it's related to fear of illness because of all of the people getting sick and dying and, respiratory concerns and all. If it may be multi-determined, and I think it will be interesting to see what happens as people start to be able to socially congregate again, if we'll see these risk behaviors increase or not. And I'm wondering if you had any thoughts on that.
Thanks for the question. I hadn't thought of the second thought you had. I interpreted this mainly to indicate that they are not coming together as much as they were previously, and that this is underlying the reduction in smoking, alcohol, drinking, and e-cigarettes. So I would assume this is the case, but I don't know. It's an interesting thought.
Professor Pataki.
Thank you. So something that you said really stimulated me to make a semi-comment, semi-question. I think it's very important to define your terms in terms of nomenclature. When you're doing a study, you always want it to be very clear what your terms mean. However, in terms of the meaning, I'm not sure social distancing and physical distancing are two independent variables. Not only do I think they interact with each other, but I think the boundaries are very blurred sometimes. So it's another consideration. If you've ever watched adolescents socialize, physical closeness or distancing is, physical closeness is social. It has social meaning. And physical distance has social meaning also. And whether you wear a mask or you don't wear a mask may not be the important thing. But I think distance, the physical distance itself, has social implications for interactions. So when you say physical distance, it's easy to understand that. That term is really simple, physical distance. You can measure it. It's very concrete. But when you say social distance, that's a little bit more difficult to define. And I do think that socializing within the context of physical distancing is really compromised.
Thank you very much. Are there any other comments? I'm going to take the liberty of making one, and that is, I thought all these presentations were fascinating, and certainly there are clear signals that there's trouble. But I think it's rather astounding, given the disastrous proportions of what's happened, both socially, distance or otherwise, economically, and from a health perspective in terms of numbers of people ill, dying, and having residual disease, that the signals aren't really stronger, and that the disruptions aren't really greater. And it seems to me that speaks a great deal to resilience, which has been rather extraordinary. And particularly amongst youth, I think the observation that the youth are maybe behaving better than the adults, it may be something really worth observing and thinking about where the strengths have appeared here, both in terms of decrease in substance use and decrease in criminal activity and other things of that sort. So I think it's going to take us some time to sort this out, which I'm glad we have longitudinal data starting to appear. But I think it's going to be a longitudinal story before we're going to really be able to understand what's happening. So I think we are about at the end of the time we have for our discussion. We need to make a quick transition to the next portion of our program, and we will just take a 5-minute break here to do that, okay? Thank you all very much.
Very complicated. Very complicated.
To start the process.
I absolutely deleted your original one.
the students about what they would like and what they think is the most important. But the most important thing I think that came from this talk is that, and something that we deal with a lot in our clinic, I direct a treatment clinic for children with anxiety and related disorders, is the tendency of many people and the media and even professionals to conflate or confuse stress and normal anxiety with problematic anxiety. So everything you read in the US about back to school is that all of these kids are going to freak out. We talk about all the kids falling off of a cliff because they've been out of school for so long, and going back is going to be terrifying and anxious, and it's going to be really problematic. And that's really hasn't been the case. What we know is that the resilient kids, the kids that are pretty healthy, they are all very excited to be back in school. They're looking forward to going back to school. A little bit of anxiety. One of my patients told me she was nervous about going back to school, and I asked her the next week, and she said it was fantastic because everybody was nervous about going back to school, and we all had that in common, and it made us feel very comfortable. The kids that we see with higher levels of anxiety and depression and more difficulties are going to have more problems. And what I'm going to be talking about more today are the kids with anxiety, with depression, with other issues, and what are some of the tips and tools that schools and parents can use to help these children manage their anxiety at home and school, again, with special attention to COVID. But again, we first need to distinguish between children that have actual anxiety and actual problems and kids that are stressed out about school or experiencing typical anxiety, as all children do about going back to school. So stress is not anxiety. Stress is a physical and an emotional reaction to circumstances that you get aroused, excited, maybe frightened, irritated, confused, whatever it might be. Stress occurs in response to good things and bad things. I'm a little stressed about having to do this talk. It gives me some energy. I'm a little nervous about doing the talk, but I'm also excited. That is completely normal and completely appropriate. Stress can occur for positive things, for negative things, for real things or imagined things. Stress is very normal. It's a completely normal part of childhood. What happens, though, is a lot of parents and teachers and even mental health professionals confuse stress when the child reports being anxious or a little confused or aroused. They see that as anxiety, and they react and they overreact. And that's one thing we don't want to do with our children. And stress is also a little bit different than anxiety, and I'll talk about that in a minute. But sometimes too much stress can be problematic. Everybody in here has gone through many years of training and has been very stressed about their training and getting into programs, of passing the exams, of doing the work. We know that stress can be difficult at times. School is the most common source of stress for children, so needless to say, back to school is going to be stressful or difficult. And most children report that time management, the pressures of school and all the things they need to do can be very stressful. These are data from the US and talking about the more recent generations, the current generation of younger people are experiencing high levels of stress. And I think we've seen over the past couple of days some graphs or trends suggesting that anxiety and depression are on the rise, triggered by the pandemic, but also, at least in the US, and I think globally, by other factors. So the Generation Z children, these are kids that are between the ages of 10 and about 25 at this point. And for the first time since these surveys have been done, the Generation Z children are reporting they are less likely to report good or excellent mental health. So our children and our children's children are reporting poorer mental health than we are, which is a really sad trend. Every generation is supposed to do better, make more money, be happier, be more productive. It's going in reverse, and it's very, very disturbing. And this is from the American Psychological Association survey from about 2 years ago. And when you look and see why children, this current generation, is reporting more stress, Look at the things that they are worried about. You can see mass shootings. Who gets killed in mass shootings? A lot of them in the US are at schools. In some of the other countries, in Norway several years ago, and in other places there have been, these kids are most vulnerable. The rise in suicide rates. They worry about climate change and global warming. Our children blame us. My kids blame me for, like, how come you didn't fix global warming? That's real to them. It's not real to us. 20 years isn't going to make that much of a difference, but it's real to this generation. Separation and deportation of immigrant and migrant families, the migrant crises. These are the friends of our children. They go to school with our children, and some of the things that are happening in the US, especially at the border, but I know in other countries as well. And then sexual harassment and other types of reports and assaults. Our kids are bearing the brunt of the societal ills that we're facing. And this can lead to anxiety, and it can lead to stress, and these are things we need to pay attention to. So how do kids report stress, managing stress? What can we use to help them? These are some of the tools that we're using in our work, is talking to the kids and seeing how we can develop some of these strategies into effective psychological first aid, as Dr. Danese was talking about. The reason I have this up is 22% say that they talk to a parent. Only 22% of kids say, I would talk to my parents to manage stress. Very low. But look at this. 75% of the kids in this survey said they want and need their parents' help. So the kids aren't going to ask for the help, but they want the parents to give it to them. So that's something very important to notice. So how can we help children manage stress, especially in the time of COVID? So here are a couple of things that we tell teachers and we tell parents on our list. We need to teach our kids what stress is and how it feels. This is a normal feeling. Your body's getting excited, your mind's getting excited. It's helping us prepare for either the good thing, the exciting thing, or the negative thing. It's how we mobilize. We need to validate our children's experience. We need to normalize. Kids can't really tell sometimes. If I'm feeling my heart beating really fast, and I'm a little kid, I don't know what that means. That's scary. It's normal. It's something that everybody feels, that everybody has, and we can give experiences, our own experiences of how we've been able to do this. Model our own stress management. We need to take care of ourselves. On the planes, when they say when the oxygen mask drops, you put it on first and then your child. We need to do the same thing. We need to model appropriate stress management, and this goes for teachers as well and parents. And then the other thing is limiting exposure to stressful events. We need to inform our children. They need to know what's going on. But if you watch CNN, I stopped watching CNN after a while. We watch it every day to see what's happening, and then you reach a point, we just can't do it anymore. So we need to help put all of this into context. We need to set and maintain daily routines. The one thing about COVID and not going to school and parents not going to work, it really has just thrown our routines out the window. Children need structure, adults need structure, we all need structure, and we need to keep attention to that. And then we need to remind kids and ourselves of past successes. We've been through things before, and you've been to school before, you've done well. When we're nervous or anxious or we're stressed out, we focus on the dangers, on the negative signals, because that's evolution, right? I mean, it's more important to recognize and react and keep ourselves safe from negative things than it is to be happy, because otherwise we're not going to be alive to be happy. So we need to focus on the past successes, and we need to keep things in perspective. So that's stress. Now, what about anxiety? There's a lot of anxiety. You've seen the slides. Kids are reporting more anxiety. How do we help and manage these kids manage anxiety? Well, anxiety falls on a continuum. And again, normal anxiety, again, is normal. Mild anxiety is extremely common. We are all a little nervous. Most people are a little nervous about the first day of school, the first day of a new job, coming to a conference internationally, and being expected to make projects and to meet with faculty, and for faculty to give talks and mentor. It's all a little bit anxiety. And for normal anxiety and mild anxiety and even subclinical anxiety, we can manage this the same way we manage stress. But when anxiety is clinical, when it is problematic to the point where it may require some intervention, then we need to intervene in different ways. And just as I've said, short-term episodes are self-correcting. I'm anxious about the first day of school. I go to school, I have fun, my anxiety disappears. How do we determine normal from problematic anxiety? How do we know when we need to do more of an intervention? Based on the intensity of the fears, the frequency of the fears. Do we get anxious and respond to things that aren't dangerous? Does the anxiety appear out of nowhere, like panic, for example? Do we avoid things we need or should be doing? Does it interfere with our lives? Is it upsetting to the children and to the family? And does it last for longer and longer periods of time? Once we start identifying problematic anxiety, we need to respond differently. So I direct a center at UCLA called the Center for Child Anxiety Resilience, Education, and Support. It's an educational center where we do community-based education programs, and I'm going to talk about some of these programs in service of preventing anxiety. So education is the best way to prevent anxiety, doing a lot of the things that I have just said. And our model is, and we have a whole environment model. You've heard of the whole child in education. The whole environment is, we want to create an environment at school, at home, in healthcare, with the coaches of the sports teams, so that everybody is on the same page, everybody's doing the same thing, everybody is sending the same message to the children in terms of promoting resilience. And I'm going to share with you some of the programs that we're doing in this regard to help manage anxiety, and especially in the time of COVID, some of the programs that we've developed to help children and families and teachers manage their children's anxiety with regard to COVID. So our approach, we use a cognitive behavioral model, which you've heard some about, and I have a little graphic here that we play for some of our children and families, and this is a little bit of a description of how anxiety works, and it sets the stage for cognitive behavior therapy. Let's see how I do this. There we go. Is the sound working? Can I turn the sound up on this? Let's see. I guess it's not working. Oh, too bad. Is there any way to get the sound? Do we have time?
Christian, can we try to connect the sound?
Okay, yeah. Let's see, let me put it back on. You might not be on presentation mode here.
Try it now, John.
Okay. Oop. Not getting it to work. Well, why don't, oh. I can't get the animation to play now. Okay. Oh, did I fall out of presentation mode?
I think it should go now.
Okay. There we go. Okay.
We think of anxiety as a cycle of thoughts, feelings, and behaviors. A child has a thought or a worry. Maybe people at school think I'm stupid. That thought causes a physical symptom, like a stomach ache. The stomach ache causes a behavior, maybe crying. Then the crying leads to another thought, such as, oh no, now I look really stupid and I don't feel good. And that thought intensifies the physical symptoms like headaches and stomach aches. All of this can lead to more efforts to get away from school or avoid going in the first place. It's a vicious cycle.
So with anxiety, that's what happens. We think something bad is going to happen, our bodies react, we might avoid, we might cry, we might get reassurance, but typically we try to avoid what we're doing. So the goal of treatment for kids with anxiety is to eliminate the avoidance. If children are afraid of something, we need to give them the tools, teach them how they can manage their anxious thoughts or their anxious emotions and do the things they need to do, which would be go to school, going to social events, meeting with family members or whatever. And there are a number of components of CBT. We work on teaching thoughts, how to manage feelings. The primary technique is exposure therapy, where we help them manage their fears or face their fears in a graded or a gradual way. We'll use like a ladder for something where do it one step at a time. If they're afraid of a dog, for example, we'll show them pictures of dogs, we'll show them movies of dogs. They'll look at a dog, a small dog, from far away and gradually get closer and closer to the dog until they realize they can manage it. Therapy for anxiety is not about making the fear disappear. We cannot make fear disappear. We can't tell somebody to stop being afraid of something. It's about learning that when they are faced with an anxious situation or when they feel afraid of something, they'll be able to manage it and they can do it, and any fears or anxieties that they have aren't going to get in their way. So this is really important for children with school anxiety that are afraid of COVID or other reasons, because they avoid school, and the more they avoid school, the more afraid they get of school, because in their mind it builds up to a bigger and bigger problem. We need to get them back into school. There are a number of reasons why children miss school, and some of it's really because of COVID now, a lot of it, but there are a lot of other fears as well, or bullying or other kinds of learning issues. The first step is we need to understand exactly what the behavior, what the underlying trigger is for them not wanting to go to school. And if it's COVID, then we can help them manage their COVID fears. So what are some of the strategies that parents can use? This is what we teach parents with anxious children, especially since they've been home from school for the past year. Be consistent. Clear expectations. You're going to be going to school. We're going to get back into our routine. We're getting up at the right time. We're having our meal. We're doing our homework at the right time. Consistency means the child can predict what's going to happen, and that's going to be very important. We can be flexible as we need, but consistency is very important. Parents need to stay calm. How many of you have children, and when the children have been anxious, you become anxious as well? Of course you do, because those are your kids. So parents, we often overreact, and anxious children tend to have anxious parents, and anxious parents tend to sometimes get more anxious than the children, which makes things worse. So we need to face our child's fears and our anxiety, and we need to be neutral, we need to be firm, but we have to stay calm, and we need to focus on the positives. Children will argue to stay home from school. They don't want to go to school. They'll argue against doing social activities because of their anxiety, whether COVID-related or not. And we need to gently but firmly, children need to do the things that they need to do, even if they're anxious. So we need to gradually give them the skills so that they can face these anxious fears. With regard to COVID especially, it's so important that we need to keep our children updated. We need to let them know what's going on, but we can't give them too much information. If the children are watching CNN or BBC or these other shows, there's way too much information. They don't understand it. And TV likes to show the pictures of people dying and all the horrible things. So we need to keep our kids updated and informed, but at a level that's as consistent with their level of development. We need to validate our children, listen to them and validate them. We need to understand what they think and correct the things that they don't understand. But we don't want to avoid excessive reassurance. We can't tell them that things are going to be okay because we don't know that. We need to keep our kids active and engaged. We need to maintain social support, and we need to use stress management skills and problem-solving skills, and we need to do them together as a family. And with our center, we teach children, parents, and teachers all the same skills. So when they use the skills at home before they go to school, the teachers will be using the same skills with them. And I'm going to show you some examples of these. We don't want parents to ask loaded questions. We ask non-leading questions in an empathetic manner. So we can say, we don't want to say, was school bad today? Were you scared? Did anything bad happen? We can say, how was school today? How was your lunch? Did you talk to any new kids, etc.? So same thing with the children. We need consistency. We teach them how to tolerate distress and anxiety, and we really focus on positive events. I'm going to skip this one because we don't have time here. A couple of tools that we use. The feelings thermometer. Thermometers tell the temperature. A feelings thermometer tells the temperature of your feelings. 100 is super anxious, very depressed. Green is calm, yellow and orange are in the middle. And before we can teach kids how to manage their anxiety, they need to know how to recognize where they are, how anxious that they're feeling. And so we can use this as a strategy for that. The other thing that we use is something called butterfly breath. These are so simple and they're so easy. Again, I'm going to show you demonstrations of these, but basically butterfly breath is you take your palm and you do a figure eight. You carve one wing of the butterfly while you're breathing in, slowly, and the other wing of the butterfly while you're breathing out. So let's all do this together just once. Breathe in, breathe out. And do that 3 or 4 times. It is so simple. And families really like it. You can do it in school, you can do it at your desk, you can do it wherever. We have a parenting program called Fuertos Juntos, or Strong Together. It's a bilingual family resilience program that we teach parents and kids together. We have taught this in multiple languages across Los Angeles County to a number of, from the most poor neighborhoods to some of the richest neighborhoods. And we just received a grant. We're developing this as an online program now. But I want to play you a clip demonstrating how these techniques work. So this will be just a couple minutes.
I would say one of the primary ones is the use of the feeling thermometer.
It's really good as a parent to know where you are on the feeling thermometer, and also for your kids to know where they are on the feeling thermometer.
Pienso yo en los regaños veces, porque veces sí como que me altero, veces muy rápido.
Pero a veces cuando tú te enojas, tú quieres que todo el mundo se desaparezca.
Your number.
Here we go. Then you have to go again on the presentation.
Okay.
I would say one of the primary ones is the use of the feeling thermometer.
It's really good as a parent to know where you are on the feeling thermometer, and also for your kids to know where they are on the feeling thermometer.
Pienso yo en los regaños veces, porque veces sí como que me altero, veces muy rápido.
Pero a veces cuando tú te enojas, tú quieres que todo el mundo se desaparezca.
Your numbers here, 25, 50, 75, and 100. In the green, you're feeling very calm. And then when you're in the red, we are the most uncomfortable. Like we may say things that we don't mean, we may yell and scream. Some people may even withdraw and not talk at all.
It's also used as a communication tool so that families can understand what the experience, what the feeling, what the emotion of another individual in their family might be.
When I come back from school, she says like, "Are you feeling good?" And I'm like, "Yes."
Si tú entraras a mi casa, tú verías el termómetro aquí, así.
Sí, lo han usado en tu casa.
Sí, así. Emily es la que se encarga de hacer copias y se las pone. Y llega Brian, Emily le dice, Brian, ve para allá, ve esa foto. ¿Cómo estás tú?
It's funny because she would just be watching out for her emotions to be able to go move the clip.
So it becomes like a family activity, which, okay.
Yeah, it's more like a fun activity.
Así, cierren los ojos. Vamos a tratar de hacer una mariposa con nuestros ojos, trazando la mariposa con el dedo. Así.
So we have an activity called butterfly breath. And it slows the breath down, calms the body.
Otra vez. Mariposa. Abran los ojos. ¿Cómo se siente?
In a very simple way for parents to be able to interact with their kids and also teach that skill of being able to come down on the thermometer.
La butterfly es la que uso mucho con el dedo. We do that often. No sé por qué será. ¿Será que los calma los nervios a las 3, 4? A veces mi esposo también.
Pero ese día hasta me dijo, ok, yo lo trato, porque vengo desesperado del trabajo. Y sí, se calmó, comimos bien, como family, yeah. I think the butterfly is really good.
Great. So again, these are really simple. These are really simple activities, and the goal is we can do therapy with children. We can teach children strategies at school for feeling better. We can teach kids strategies at home for feeling better. But you need to do it. We need to make sure everybody's on the same page, because if we're teaching children how to do these strategies and they come home and decide that father was at the last woman with the butterfly, dad comes home from work, he's agitated, we all, all the stress. Look at the parents, how much stress we've all gone through for this. So we need to really work hard to get everybody on the same page. And we need strategies that are simple, that are straightforward, that are effective, that our children and our parents and our teachers can use. So what about school? We just have a couple minutes left. And these are strategies that we give to teachers. So anxious children do not like to be the center of attention. These are the children in the class that never raise their hand, they never want to be called on. And we have children coming into our clinic that they get in trouble at school because they don't talk. Or if they do something that maybe is embarrassing, the teacher may call them out in front of the class, which makes things a lot worse. So we tell the teachers, when you're working with anxious children, you need to check in privately. You can't call them out in public because it's very difficult. You need to give the children a specific person or a contact person that they can talk to when they're feeling bad. We don't want the children getting so anxious that they have to go home. They call their parent and they go home, or they melt down, or they do something really embarrassing in school, like cry or have a tantrum, that is going to make it very difficult for them to go back. So they need to have safety outlets, people that they can go to. We do these exercises classroom-wide, like butterfly breath and feeling thermometer and other techniques. So we have schools where we've taught meditation strategies or mindfulness strategies, and every morning the whole class does it together. After lunch they do it together, and right before they go home they do them together. Because we need to keep calm environments and environments that are going to support our children, because we're living in a very stressful time with COVID. And again, most children are doing just fine, but for those portion of kids that aren't, it's important to create helpful places for them. And we need to really build in extracurriculars and fun. This webinar that I did, the back to school, I asked the two, there was a boy and a girl, a 9th grader and a 12th grader. I said, what advice would you have for children that haven't gone back to school yet, for your friends? And they said, you need to do fun things at school. They said, the best thing about going back to school was doing fun things with my friends. So we need to focus on the positives and get these kids engaged in things that they want to do. We need to be at school. We have to give kids choices, but we don't let them do whatever they want. The worst thing you can do to an anxious child is ask them an open-ended question. Well, what would you like to do? That makes them more anxious. We need to give them strategies. Okay, if you're feeling anxious, would you like to do butterfly breath at your desk for a couple of minutes, or would you like to go down and get a drink of water and then come back? 2 choices, they get to pick, they're in control, but really we're in control. So if you are a teacher or a parent, which one of these things, if a child says, I'm scared or frightened about something, can you read these? Don't be silly. Why would you be anxious about that? Is that a good response for an anxious child? Wow, this might be too much for you. I agree, you should be anxious. Everything is going to be okay. Don't worry, you don't have to do this. Is this a good response? Not at all. I can see that you're feeling anxious right now. Let's take a few minutes and then try this again. You've got this. Yeah, good. Oh, you guys are great. But how many times do you think the right question is the one that teachers or parents or even therapists use? It's kind of the hard one. It's kind of the hard one, isn't it? So we have an online anxiety training that we have developed And it follows four children, one, Matteo with separation anxiety, Maya, who just has normal anxiety, normal stress, Liam has social anxiety, and Sophia has generalized anxiety disorder. And this course follows each of these four kids. Each child has about a 15-minute segment. And it shows the child going to school and reaching kind of a crisis point with their anxiety. And then the people that take the class, and it's for anybody that works in a school, nurses, janitors, the cooks, the teachers, everybody that comes into contact with children, they have to decide what the child should do. And then there's a right answer and a wrong answer. And then if they decide one thing, then the tape continues to play the video, the story, and they see what happens. If they choose the other, then they see the other thing that happens. And I know we have very little time, but this is about a 30-second clip that I want to try to play for you. And let's see if I can do this.
No! Matteo, hey, you gotta go to class. Your teacher's gonna be waiting. Hey. I understand you're afraid. But there's no reason to be. You're gonna be just fine.
Why can't I just stay home with you?
Buddy, Daddy's gotta work today.
You'll still be home.
Yeah, I know, but look, my job is at home. And your job is here at school.
So the person has asked a question, and again, the video continues based on either one of these. And we have a number of materials for the teachers, for parents and children, working with the parents and teachers together, rating forms and strategies. Here's an example of a brave behavior chart. So Matteo has target behaviors to work on, that he works on at school and at home, and he gets rewards. And I'm not going to show the next one. This is social anxiety.
All right.
Oops. And again, same things here. Strategies. We have tip sheets for parents and teachers. We have strategies for kids. We have a youth advisory group that's working with us to create strategies for kids as well. Very similar to Dr. Danese's presentation, social media, etc. And again, the idea is you have to work in all areas that affect the children's lives, and that's going to be what we're trying to do here to help these kids get back together. We all need to work together. Here's our website. We have a lot of materials. You can see all this stuff there if you'd like, and make use of some of our practices. I'm done. I think I went 1 minute over, but I talked as fast as I could. Thank you very much.
Thank you, John.
We'll do the discussion after, right?
Thank you, John. Now, I invite Pietro Pietrini, because we have a small change in the list of the... Pietro Pietrini, if he join us, is Professor Pietrini is a professor at the University of Lucca, and is the chair of the School of Studi in Lucca, that is a wonderful center for studying in neuroscience and other fields. And Pietro will speak about emotion and behavior in the brain.
Hang on just a minute, I gotta get your slides up. You can see here, and you can advance the slides with this.
Okay, so can I move over back?
Yeah. And your microphone is on right here.
Okay, so good morning, everyone. And
It's a true pleasure to be here today for at least two reasons. The first one is that, is a general one, is that this is the first meeting in person after almost 2 years. As a matter of fact, I remember that I gave a talk to almost 700 young students in a theater in Milan on February 19 in 2020. So exactly a few days before the lockdown. That was my last presence in public. So it's a real pleasure. The second is specific to this seminar, because this is a wonderful meeting, a wonderful opportunity to interact for young people, to interact all together with younger and not so younger anymore people like myself. And so I wish to thank the organizers, in particular Professor Caffo and Professor Leventhal, for again inviting me and giving me this opportunity. So, not to use more time, we had already a talk on, I gave already a talk to you on Monday, and we went into the general, let's say general basis and some examples of applications of neuroimaging techniques, of how we can basically start this travel into the brain to understand the human mind. Today, my topic will be on emotion and behavior. Of course, will be a sort of, not so for the topic and the time given, will be just a perspective on what we can do to try to understand emotion and behavior and how we control emotion and behavior. As a matter of fact, the talk that preceded me is very relevant, because you saw how emotion and behavior and control of behavior and the influences of emotion on behavior are crucial for our daily life in children as well as in adults. So I think that this basic lesson will actually be very complementary to the talk that I just preceded. So to proceed is this one, I guess. Okay, we just talked about it. So when how we go from making a behavioral choice from instinct and emotion. What starts our behavior, how we generate a behavior. Let's see how this is relevant, and also how this is relevant, if you want, in society, because if you think, and this is a topic of great interest for our group, if you think of impulse crimes, you know, we all have impulses, but thanks God, these impulses for most of the times are innocent impulses. We may shout, we may, you know, punch our hands on a table or break something, but rarely will kill someone out of an impulse. But there are impulsive crimes. So the free will in these terms is the ability not to respond automatically to an instinct or an impulse that we experience. How much is this ability? How great is this ability? Is this ability always present or can be compromised by specific factors? And this is the topic that I like to talk to you today. So I told you, you know, if you want to be schematic, and I apologize for being maybe too schematic, but for didactic reasons I want to be schematic. A behavioral output is the balance between instinct, emotion on one side, and reason, the filter of reason, in a rational filter on the other side. So if I ask you what you think is going to happen in the next slide, I guess many of you would say the bear will eat the salmon, right? Then there is always somebody very optimistic who says the salmon will survive, will escape. Well, neither answers are correct. Or at least the first one, let's say, is partially correct, because it's true that the bear will eat the salmon. But that is a simplified answer, because the bear will eat the salmon, but in this particular way. The bear will peel off the skin out of the salmon, throw away the very good wild salmon, which is, you know, very expensive if you want to go, if you go and buy wild salmon, and will just eat the skin. Why does the bear do this? Well, this is not a choice, a rational choice. It's something that the bear does because the bear is genetically programmed to like fatter things than slim things. And the fat in the salmon, as in any animal, humans included, is under the skin. So what happens is that the bear, in order to prepare for the winter, has to have a lot of fat to build up the so-called brown fat. Brown fat is a particular fat that even newborns have when they are born, which basically provides energy for the winter in this case, and for us, for the passage from the mother's womb to the external environment. Of course, this for humans is a sort of heritage that we have, because now we are born in hospitals, and taken care immediately. But think of in terms of naturalistic environment in the wild. In the wild, you would need this. What I told you is not the outcome of a long reasoning by the bear like I did. So the winter is coming, I need energy, I need to eat fat. It's just genetically programmed, which, by the way, is the same reason why all of us like more sweeter things, fatter things than salad. And then we force ourselves to eat salad because, of course, at least in many parts of the world, unfortunately not in all the parts of the world, we have abundance of resources and food is delivered to your house, so you don't have to run for days in the cold to catch a prey anymore. So we think that in animals, behavior is mostly dictated by instinct emotion. It is an automatic response to what? An instinct, an emotion, if we can call that an emotion, a pre-programmed instinct is driving the behavior. Which doesn't mean that animals cannot decide, cannot make up their mind, cannot control their behavior. As a matter of fact, this is my older golden, unfortunately passed away last June when he was 14-year-old and 2 months old. This was much younger. We were in Venice together, and he was a very, he really liked food, but as you can see here, he's drooling, he's looking, fixing these meatballs, but he knows that unless I gave them to him or I told him go, he wouldn't take the food. So he could control his behavior. The same way he could play with you with his mouth and not making any harm to you, or breaking into pieces a piece of wood, the stick, with just one bite. So animals can control their behavior and can even understand when they have to do something or not. So animals have controls of behavior, meaning that they are able to plan an action. But the reason why we think our behavior is very different from animal behavior comes from basically this cartoon, which you already saw on Monday, showing that, I don't know if I can do this, showing that the prefrontal cortex, this violet part, as you can see, has enlarged, has grown much more as compared to the rest of the brain in humans as compared to other animals, including chimpanzee or even the dogs that, as I said, which have cognitive functions that are similar to humans, even theory of mind or other things. So because of this, we know our behavior is different, and we can do abstract planning, we can control our emotion in a much more sophisticated way than animals do. And the beautiful lesson that just preceded mine really made a very important clinical point on this. What happens when we lose this ability? Because if our behavior we think is mostly governed by reason, which is actually is not very, very true, we also know there is a wonderful model, wonderful from a scientific point of view, humanly speaking is a tragedy, which is frontal lobe dementia. We have a natural model, it's a disease. Frontal lobe dementia is a disorder of the prefrontal cortex, so that violet part of the brain that I showed you before in the cartoon, violet in the cartoon, of course. Here you see a patient that who I studied over 20 years ago. This subject was 37-year-old. The top row is the MRI and PET scan with FDG, fluorodeoxyglucose, basically glucose metabolism, which is an index of neuronal synaptic activity. Going from blue to red there is an increase in glucose utilization. So yellow-red is better than blue and green. And I was told that in Roma, yellow-red being better is very appreciated. For those who are not from Rome, I think are the colors of a local team. Okay, so soccer team. So 10 months later, which is the bottom row, you can see how dramatic the lesion became. So he basically lost his frontal lobes. You see here, look at this, just this. Looks like it has been cut with a knife. The back of the brain is still is still relatively active. The frontal parts, the frontotemporal, are gone. This subject died, and we performed the autopsy, and I took him, at those times I was still in the United States, I brought him in the United States the brain, and we did some molecular analysis. We discovered the second mutation of a tau protein in this subject. But what is interesting is this. This is just a short part of an interview with his wife. And she said, "My husband behaves like an animal. He used to be the most affectionate person I have ever known in my life. Now I could drop dead to his feet, and he would step over me to go to the refrigerator and stuff himself without pausing," which basically he was doing what the bear would do, just following instinct and not mind anything else. So clearly the frontal lobes are important for emotional control, for behavior, for decision, for judging between what is good and what is bad, and for controlling aggressive behavior. This is a study that is over 20 years old, but was the first study that we showed for the first time that the moment in which young subjects like yourself, these were college students asked to become aggressive, to imagine to become aggressive. While we were imagining to become aggressive, because what we call a script, an aggressive script, this is a study I performed with my late Mario, not at that time, with Mario Guazzelli, who was professor of psychiatry in Pisa, and then he died almost 10 years ago. And we showed for the first time that when you do this, there is a shutdown in the frontal cortex. What you see here in the cartoon of the American Journal of Psychiatry, and here in terms of more scientific data, is that the ventromedial cortex is functionally suppressed the moment individuals become aggressive. So the part of the cortex that when it's lesioned, when it's by a tumor or by an accident or by a disease, is associated with release of aggressive behavior, of uncontrolled behavior, is the part of the brain that in a healthy human subject is shut down when they become aggressive. So, already this few information combined with those that I gave you in my talk, during my talk on Monday, are enough to say that we are our brain. This is what Stephen Lorace and Giulio Tononi wrote in the introduction of this book, Neurology of Consciousness, where I contributed a couple of chapters on these topics. We are our brain, but if we are our brain, then we can take this a little bit further and ask, well, how much this being our brain impacts on our social behavior? Can we try to understand criminal behavior, abnormal behavior by studying the brain? So, in other terms, psychopath criminals, bad or mad, where bad is, they are bad because they want to be bad. They know what it means to be bad. They could do otherwise, but they decide to be bad. And mad, this is a pun, mad would be they are bad because they are unable to do otherwise. They don't understand what it means to be bad, okay? Bad or mad. Well, this bad or mad starts. Well, many, many years ago, this is the British psychiatrist Henry Moseley. Look what he wrote. This was, late 19th century, so this was much earlier and much before any neuroscientific tool. If you think that EEG is 1929, so there was no way to do to assess the brain otherwise. And Moseley, after studying these people, said, as there are persons who cannot distinguish certain colors, having what is called color blindness, and others who, having no ear for music, cannot distinguish one tune from another. So there are some few who are congenitally deprived of moral sense. He basically compared these people to colorblind people. He say, they are deprived of moral sense. It's like people who cannot see colors. So it's not a choice. I mean, colorblind people do not decide not to see a color. They don't even know what you are talking about. And psychopathy really is important in criminal behavior. If you look at this picture requires no words. This is the level of psychopathy, the average level of psychopathy in the inmates, so in people who are in jail in the United States, and this is in general population. Well, you see by yourself that there are 6-7 times higher psychopathy among criminals than in the general population. This is so relevant that there is a dispute in forensic psychiatry, because somebody says, well, we cannot consider psychopathy a reason of insanity because it's so common. And other people like myself who say, well, it doesn't matter if it's common. We need to understand what this does on criminal, because it's like saying you go to a neurology department, you say that epilepsy is not a disease because it's so common. I mean, it doesn't make any sense taken to an extreme. And this would be actually a very nice topic for a future presentation or something. But this is very relevant also for younger, especially for younger individuals, because when you go to jail, somebody goes to jail and somebody is put to jail, the real problem is to rehabilitate the subject, to restitute to society, to give back to society a different person. In other words, to predict future behavior. Well, if you look at this graph, it tells you that after being freed from jail, the percentage of recidivation, not recidivating, so people who do not commit another crime, is a function of a level of psychopathy. If psychopathy is very low, you can see that even almost 4 years later, 1,200 days later, only 20% of people have recidivated. But if psychopathy is very high, you have that in the first year, 60% of people have recidivated. So this is very important. Psychopathy predict future behavior. So we have to understand psychopathy, to study psychopathy, to act on psychopathy. And, when if you put everything together, and now we have these tools that I described to you, and you go and you measure structural volume, so neuronal density, thickness of a gray matter cortex, of a gray cortex in the brain of healthy subject and subject with abnormal behavior, no surprise. You find that the differences, the group differences between the two are here in the prefrontal, ventromedial prefrontal cortex. Criminal people have a significantly reduced or significantly lower, to be more precise, neuronal density. In the same area, if you remember the slide I showed you before of our study in the American Journal of Psychiatry, in the same area which is crucial to control behavior, which is shut down when you become aggressive. These people have statistically significant fewer neurons. And you see also neurons in some limbic emotional structure. So are not general differences in the brain, are differences in brain areas relevant for emotional processing and control of behavior. And this survives even if you correct for different level of education, trauma, substance abuse, so all those things that may differ between healthy controls and people with abnormal criminal behavior, so survives. I still have some time, so okay. So exactly, I was showing you that this picture is exactly the same area that I showed you devoted to control of behavior. We can now study, I mentioned you quickly on Monday, using magnetic resonance imaging, in particular technique, you can even visualize the fiber tracks that go from one part of the brain to another part, and the different colors tell you are different fiber tracks, are different directions. So this is basically a normal brain. You should imagine around here all the cortex. It's like cutting this way. Imagine my brain cut from above to top bottom, and these are the corpus callosum, and this in blue are the pyramidal tracks going down. You can measure thickness, direction, so how many fibers there are. And if you do this again in criminals, as comparing psychopathic criminals as compared to healthy controls, you find interesting things, that areas of the brain like the orbitofrontal cortex, which we already saw and discussed, being so crucial in controlling behavior, and the amygdala. We haven't talked about the amygdala, but the amygdala is the emotional computer of the brain. The amygdala is powerful structure which reacts immediately, even subliminally, to subliminal stimuli, emotional stimuli, while this uncinate fasciculus, which is the fiber track which connects amygdala, the emotional computer in the brain, to the orbitofrontal cortex, is significantly reduced in criminal as compared to healthy controls. So we have a sort of a structural and functional neuroanatomy of abnormal social behavior, which is really prompts some intriguing observation. Since I don't have time today, I skipped over the part where we apply this to forensic psychiatry in real cases, but maybe we can do another time. And I want to touch upon another point that I showed you on Monday when I mentioned that now we have powerful tools to try to understand human behavior and human cognition. And alongside with functional and structural brain imaging, we have the huge progresses of molecular genetics and molecular biology. And now we can understand, or try to understand, how genes, how different genetic variants may influence the way we develop, the way we become, the way our personality is formed, and how we respond to the environment. The premise is that as human beings, we all have the same genome, 22,000 genes, more or less. But the reason why no one is identical to anybody else unless he or she has an identical twin is because on this 22,000 genes, there are more than 35 million of variations. Variation that can be as small as a single letter of a DNA, what is called single nucleotide polymorphism. So let's say that if this one, the first one is a piece of a gene of you, and the other one is a piece of the same gene in the person which is who is sit next to you, the T instead of a C may explain why you have a darker color of hair, for example. Okay? But as a matter of fact, these differences may affect a lot of things, including the way we respond to the environment. And I want to show you, since I have still a few minutes, I think, I want to show you where we can take this, and I'm going to show you the results of a study that we conducted in collaboration with University of Pisa with Professor Silvia Pellegrini, who's actually here also because is my wife. She's here only because it's my wife, because, but she did the study, she's the author of this study, and of course she could give this talk much better than I will. So is morality in our genes? Can genes influence moral decision? What Silvia and our collaborators did a couple of years ago, we took 200 university students who were screened to exclude psychopathology, behavioral problems, and they were asked to respond to 56 moral dilemmas. At the same time, we collected saliva with a tube, a special tube. She did DNA extraction, and we genotyped the DNA of this subject. Of course, all this was approved by the committees, and all the subject gave informed consent, and privacy was preserved. But the interesting thing was this. They were asked to evaluate the willingness to engage in the given action of a moral dilemma, moral dilemmas, I'm going to show you an example, and say whether this choice was morally acceptable or not, from 0, not acceptable at all, to 7, totally acceptable. This is a classical example of moral dilemma. There is a runaway trolley barreling down the railway tracks. Head on the tracks, there are 5 people tied up and unable to move. The trolley is headed straight for them. You are standing some distance off in the train yard next to a lever. If you pull this lever, the trolley will switch to a different set of tracks. Unfortunately, you notice that there is one person on the side track. You pull the lever, diverting the trolley onto the side track where it will kill one person. Would you engage in this action? What would you say? Quickly. Who would say yes? Raise your hands. Who will say yes? Who will pull the lever? Just these few? Who would say no? What is it? Abstinence. So either yes or no. Okay, so, well, I tell you that you're a little bit shy. Usually when I do this, 80% of people say yes, 20% of people say no, because, you know, you say 5 minus 1 is 4, you say 4 people. If you change this moral dilemma, I don't have a slide, and you say, you know, the machine is exactly the same, but you have to stop the barrel by throwing a person down a bridge on the track, 80% of people say no, and 20% of people say yes. So it's just the opposite. But, and it shows you why, you know, are called moral dilemma. So you ask people to respond to 56 as this moral dilemma. They can say yes or no, like this. They can say it's moral acceptable. To make a long story short, we went to look at the genetic polymorphism which modulate dopaminergic function. Why dopamine? Because dopamine is crucial in cognition and behavior, and there is a huge literature on this, so I have no time to go on to this. To make, again, a long story short, what you have to understand here, besides all this little acronyms and titles, is this. The higher the number, the stronger is the dopaminergic modulation. So people who have the polymorphism with 1, and you can sum up all the different genes, the higher the number, the better is the dopaminergic transmission. And what you see here in the genetic results is that, if you go here in the frequency of yes, is that the females with genes that are associated with a higher dopaminergic transmission respond more yes than females with the other genetic variation, with genetic alleles. In other words, the genes which promote dopaminergic transmission make women to respond more like males. So in what is called utilitarian way, in a more rational way rather than emotional way. And this is consistent with literature with other different methodologies going on the same point. So in other words, this study, which you can find here, is published and is free of access, so you can download and look into details, given that here we have little time. In other words, what happens is that different genetic assessment appear to be associated with a different way in which we interpret and respond to moral dilemmas. So, I want to skip this and go to this because I think time is over. There are several variants in genes that modulate neurotransmitters in the brain, enzymes for neurotransmitters, so whatever it is the overall metabolic environment in the brain. Several studies, including many studies by us, have shown that this gene may modulate the way you interact with the environment, so that these genes are now called plasticity genes, and this is important to understand. If an individual has none of this plasticity gene, so as the variants who make him or her less permeable to the environment, what you see here is that it really is indifferent whether as a child as children we were raised in a family, in a happy family, in a positive family, or in a negative family. The probability to become a good or a bad person as an adult are sort of independent from this environment. On the other hand, what you see here is that if we had all these 5 variants, I skipped for reason of times, but just trust me on my word, there are these variants for the same genes that increase the permeability to the environment. Well, what you see here is that if we were raised in a bad family, so we were neglected, we were beaten up, we were not given all the resources, psychological and physical resources we need, they have a much greater probability of becoming bad as adults. There is no determinism. It's just a risk factor. There is no deterministic effect. But to look at also this is what we are studying, actually, Professor Pellegrini is studying in Pisa, is prosocial behavior. What looks like, but if you look at this data, is that if you have these genes, and you were raised in a very positive family, you may even become more prosocial than what is in the general population. So in other words, and this is my take-home message, historically, scientists have looked at nature and nurture as 2 separate pathways, 2 different avenues that never crossed, with different alternating success during history. You know that there was a very positivism in the early 1900s, biologically determinism. Then later on, it's all fault of nature, of environment. As a matter of fact, nature and nurture are the 2 faces of the same coin, are the yin and yang of our life. And nature modulates the way we interact with the environment, and at the same time the environment modulates our genes. You know that there is this sort of new science, epigenetics, which basically is able to understand or pursues the study of the effects of environment on our genes, of the expression of our genes. Our genes do not change. I mean, our genome, remains the same, but the way our genes are expressed, how much they work, can be modulated by a drug, by a caress, by the word of a psychotherapist, for example. So think how close and how deep is the interaction between our biological roots and the environment in which we live, which are 2 inscindable things. And I stop here and thank you for your attention.
Some comments? No, I like to thank Pietro because his speech was absolutely. They continue what very interesting because they continue your speech of Monday and now you will spread this process that will be can be very important. You suggest many issues and that we have to discuss after that. I asked to Alberto of Siracusano to comment and 2 comments to. All this morning, Alberto is a professor of psychiatry. Alberto Siracusano is professor of psychiatry at the University of Rome, and was president of the Italian Society of Psychopathology. We have in family some child psychiatrists that are very connected with our process because the daughter of Alberto came 2 times in our research seminar, and Alberto is one person that is between adult and child psychiatry for many years, and we know each other for a long time. To you, Alberto.
Thank you, Ernesto. Thank you, Professor Leventhal. I'm very honored to be here and to speak after the friend, Professor Pietrini. I am the last speaker, so we said in Italy, triste il destino dell'ultimo relatore. So, sad is the destiny of the last speakers. So I will reduce my presentation. I will speak a sort of Italian, English, Italian idioms, because I was unprepared to speak with these slides that are new for me. In the first part, I will say something about the COVID and mental health. In the second, I will try to explain a new concept that I think is very important. It is a concept to use like a new models to study the mental health and the well-being situation. And finally, I will say something about the new direction. So I start with these. These slides. These slides just to reflect about a thing that about 1 billion people of the global population has mental problems. And the young people are the 41%. So 410 millions of child has problems. And how many are the peoples in the world? This is the last number of the UNICEF, that comes from UNICEF, and are 2.2 billion of children in the world. So we have many, many people with young people. So we need of many psychologists, neuropsychiatri infantili, to study the young mental health. This is our study about pandemic and lockdown measures impact of mental health among the general population in Italy. It's one of the first articles in the field. And we are, diciamo, io penso che questi siano dei risultati scontati. I think that are obvious results. Post-traumatic stress disorder, depression, anxiety, insomnia, stress, and adjustment disorder. It's obvious that COVID impact on mental health in this mode. But what is new? That we think that we can fit the COVID or the mental health disturbance. We need to use resilience. And we propose a new concept of organization. The organization is a resilient hospital. Tor Vergata è l'ospedale dove io lavoro, is the hospital in that I work, and we was at the beginning a COVID hospital. So we try to modify our organization. And what means organization? Organization means architecture, administrative. So not only the building, but also the person. So the resilience of the person is one of the most important things to fight the COVID and the mental disturbance. Diffusing was one technique that we have done to help our colleagues. The traumatic effects of COVID on childhood is, and the other one, okay. So we have the effects of remote learning on social relationship. This is, we said before, Professor Lucidi and other speakers about the distance, but we have proposed this concept, the skin anger. The skin anger is one of the big problems that we now see in the young people. And so, perché è importante trovare una strategia di cura del skin anger? Perché when we speak about this problem, we are speaking about the relation between two persons, one adult, one child, two child, and the relation is a very complex modality to stay together. Traumatic exposure to mediatic information pandemia impact on children's mental health, obesity, substance abuse, so many things. But special needs, neuropsychiatric disorder, and COVID-19. Mental disorders are like contributing factors to mortality following COVID-19. So what I want to say, that the COVID, the pandemic period, ha portato a confrontarci col concetto della morte e a riflettere su che cosa vuol dire morire oggi. Molti giovani hanno scoperto la morte con l'esperienza del Covid. Prima questa non era così conosciuta o vissuta o presa in considerazione dalle giovani popolazioni. Now I will try to, I said before, Italian English. The pandemic experience and the death during the pandemic experience, one of the consequences è stata che the young people, the new generation, knows what means death. Not that like virtual, like as in the virtual games, but in the reality. So there is a real culture transformation, revolution. And this is the first part on COVID. The second is about a relation with the determinants of mental health. Because we think that COVID is a social determinant of mental health. We use COVID like a model, because now have more things than that not only the COVID. Because we can design in this cartoon the multidimensionality of povertà e salute mentale. We have many notions about poverty. Poverty is also obviously things linked to mental health. But there is a kind of poverty that is not material, is spiritual. It is, in our concept, povertà vitale, vital poverty. Because it's important, because la povertà vitale, the virtual poverty, is our value, our relation, our emotion, our affects. And in a world with vital poverty, we have many mental disturbances. So we need to design new models of intervention on this virtual poverty. The poverty of the life emotional is una bomba, is a nuclear bomb. Okay, povertà assoluta, materials, and povertà vitale. These items are needs to understand devono essere capiti e studiati per proteggere i ragazzi. Okay. Behind the social economic status, the concept of vital poverty, okay, I said before, this is our study about the resilience and vital poverty. But I want to say in conclusion, this is a very interesting study, the trifecta of misery and disease, vulnerability, poverty, childhood maltreatment, and inflammation. This study is very important to know what happens when we are we find these diverse things in the life of a child. But I want to say, okay, in the last part of my presentation, something about prevention. Because prevention of psychiatry, improving mental health of young people. So this is, we have usually three models of prevention: primary, secondary, and tertiary. And this is the concept that I will underline. In clinical high risk, in this period, the transition period, we need to analyze and to intercept the first signals that are at basic of the symptoms. And so we match this concept with vital poverty, we can find a large range of risk factors. So we need money. We need money to study this transitional phase, the transitional phase between childhood and adulthood. Okay, transition is a topic in psychiatric training through Europe, trainer's perspective. This to underline my idea. Machine learning in psychiatry are the last conclusion, the new models to study and to use for therapy. So this is the last mental late-night wasting quality, and this is the last slides. Covid-19 and the need for action on mental health. So, l'Italia dovrebbe investire 2 miliardi di euro per la salute mentale. We need money for the research and for the new models. I'm sorry for my English. I hope that the next time I will speak only in Italian.
Thank you, Alberto. I'd like to ask to Bennett if he'd like to say some comments about our testimony, because he was listening today. It was a special moment because in general Bennett is speaking, but today he was listening. But I know we discussed during those months together about COVID, about the situation, and for this we decided to have this morning this topic in our table.
Well, I want to begin by apologizing to Alberto for my Italian. It's not so good. Listen, we're in a remarkable time. I suppose we can be narcissistic and think that it's never happened before, and what we're facing is unique, but probably not so much. On the other hand, we're probably learning things that we didn't know before. COVID is an infection by a virus, but that virus in and of itself has made many people ill and sick and dead. But the attendant events around COVID have perhaps been as damaging as the infection itself. Failures in political leadership, human selfishness, pursuit of power in the face of opportunity when other people needed care, and insensitivity to children, families, and community structures have been somewhat staggering and a surprise. And what we're faced with is a complete disruption in many structures that are important to children in particular and families secondarily. Things like jobs, ability to work and earn a living, but having a job also has pride and dignity associated with it as well. And our ability to feel that our children are safe and that we can provide safe homes, safe schools for them. And yes, we have to remember schools as well. So while we may have disputed earlier whether the issue is physical distance or social distance, certainly our children have been distanced not only from each other, but the opportunity to learn. And what they learn in school is not just reading and mathematics and science. They also learn to work together and to live together collectively. And that has been taken away from them by virtue of an infection and by virtue of things that are more related to our social failures. And what we've heard today is that the consequences of that have been substantial. There's an increase in certain mental disorders. There's an increased risk for other mental disorders. And there have been all manner of disruptions that are ominous and portend difficult things in the future. But we've also heard from our speakers today that there's a way to prevent problems, that there's opportunity to seize on previously unrecognized resilience in our youth and in our parents, and that we're at a turning point. And we can make a decision to be defeated by COVID, or we can follow the advice of our colleagues, John Piacentini, about active interventions for dealing with anxiety and behavior, Pietro Pietrini about understanding how the brain drives behavior and taking advantage of that knowledge, Professor Lucidi about his ideas about working with closeness, Professor Hebebrand's notion that we need to understand what's happening and that looking at the literature and creating more science and pursuing that science is vitally important. And of course, Andrea Danese's careful understanding and approaches to the issues of trauma and how that affects our youth. So I would say this morning gave us a warning, but most of all, gave us some hope that we're not defeated yet. And despite the fact that some people would prefer to focus on the bad news and on the failures and on the foolishness, including foolishness of our peers, I think we're at a time that we need to decide we're not going to focus on that. We're going to focus on what our knowledge has given us, create new knowledge, and move forward to protect our youth so that they can have a future instead of giving them a future that is dark and ominous. So I'd say good news today in a dark time. And so I thank all of our speakers for really being able to share their knowledge, their experience, and their wisdom, because I think it's been really helpful. And it's, I'm feeling more positive. Thank you.
Thank you, Bennett. I thank all of you, and we will see this afternoon at 6 o'clock in Italia Embassy to continue this discussion. And I know that for the resident, for the participant, today is a wonderful day because Rome is open for you, and we will see at 6 o'clock tonight.